And some other genetic syndromes sometimes are associated with diabetes. These include Down syndrome, Turner syndrome, and other types of syndrome that are usually associated with diabetes. So the general classification of diabetes is type 1, the immune-mediated, type 2, the insulin-resistant type, and type 3, the maturity onset diabetes of the young. So in type 1, this is usually the persons who have type 1 are usually not obese and often have recent weight loss. And it can be due to short duration with symptoms such as thirst and frequent urination, with presence of ketones at diagnosis, as about 35% present at first with ketoacidosis. So often there is a honeymoon period after the blood sugars are in control, during which the need for insulin diminish for a while, and low doses of long-acting insulin such as Glargine, Lantus may prolong this phase in order to control the blood glucose after a period of complications. So the ultimate complete destruction of the insulin-producing cells that need exogenous insulin for survival. And this will have ongoing risk for ketoacidosis, and only about 5% will have family history in a first or second degree relative with diabetes. While in type 2 diabetes, which is the insulin-resistant type, patients who have this type are usually overweight at diagnosis with little or no weight loss at all. They also usually have sugar in the urine, but no ketones, and as many as 30% will have some ketones in urine during diagnosis. While about 5% will have ketoacidosis at diagnosis, and often little or no thirst and minimal increased urination are present. Also, in this type, there is a strong family history of diabetes, which will increase the risk of occurrence, as about 50 to 80% will have at least one parent with diabetes, and it can span across many generations of the family members. Also, about 75 up to 100% will have a first or second degree relative who have diabetes. And typically, it is more present or more prevalent in certain ethnic groups than others, such as African, Hispanic, Asian, or American Indian origin. So disorders that are likely to cause insulin resistance are common, and about 90% of children with type 2 diabetes can have dark, shiny patches on the skin, which are known as acanthosis nigricans, which are most often found between the fingers and between the toes, and even on the back of the neck, which is regarded as a dirty neck, and in the axillary creases. And for the maturity onset diabetes of the young, this is a rare form of diabetes and can have several varieties. So it is characterized by early age of onset, which is between the ages of 9 and 25, with an autosomal dominant inheritability. It also results from defects to the insulin-producing cells that are caused by genetic defects in the pancreatic beta cell function, and symptoms run the gamut from mild elevation in the blood sugars to severe disturbances. So MODY can occur in all ethnic groups, and the gene abnormalities are rare and can only be identified through testing that is currently available only in research laboratories. And patients are usually not obese. So environmental stressors such as illnesses or puberty may unmask the genetically limited insulin secretory reserve of the patient with undiagnosed MOD. And unlike type 1 diabetes, it doesn't cause polyuria, thirst, or extreme hunger. Also, the primary goal is euglycemia. So fasting insulin and C-peptide levels are usually normal or elevated slightly. And for assessment, we should assess for mood disorders, for contraceptions with the reproductive and sexual history, also the current treatment medications, their meal planning, their glucose monitoring results, and the patient use of data. In addition, we should assess the eating patterns, the nutritional status, and weight history with growth and development in children and adolescents. We should also assess exercise history, family history of diabetes and other endocrine disease, in addition to the frequency, severity, and cause of acute complications such as ketoacidosis and hypoglycemia. Also, history and treatment of other conditions, including endocrine and eating disorders, with infections, skin, foot, dental, and urinary tract for the diabetes. And laboratory tests should also be assessed with symptoms and special examination results that are related to the diagnosis of diabetes, in addition to assessing lifestyle, cultural, and psychosocial or even educational factors that can influence the management of diabetes. And other medications that may affect blood glucose level should also be assessed with previous treatment programs such as nutrition and self-management education and the patient's health beliefs. And most importantly, we should also assess any prior A1C levels that has been obtained or obtained from the patient. So risk factors for atherosclerosis such as smoking and hypertension should also be assessed, in addition to assessing obesity, dyslipidemia, and family history of other related disease. And an important consideration, in particular in children, we should assess the symptoms of celiac disease in those with type 1 diabetes. And also very important to assess the symptoms and of the chronic eye, kidney, and nerve disorders with other GI functions, also assessing the associated complications with diabetes, such as foot ulcers and other related or associated issues. So evaluation for diabetes focus on screening for prediabetes first and diabetes in the high-risk asymptomatic undiagnosed adults and children. Also, an oral glucose tolerance test may be considered in patients with impaired fasting glucose to better define the risk of diabetes. In addition, testing for diabetes should be considered in all individuals at ages 45 years and above, in particular in those with a BMI of 25 and above if normal. And testing should be repeated at least at every 3 years interval. So the classic symptoms of diabetes includes polyuria, polydipsia, and unexplained weight loss plus one of the following. First, symptoms of diabetes and a casual plasma glucose of 200, and casual is defined as any time of the day without regard to the time since the last meal was consumed. Also, fasting plasma glucose with a 2-hour oral glucose tolerance test of 75-gram glucose load, or even both are appropriate. In addition, assessment of the 2-hour plasma glucose of 200 milligram during an oral glucose tolerance test, and the test should be performed using a glucose load containing equivalent of 75 grams of anhydrous glucose that is dissolved in water. And for the medical nutrition therapy, we should replace the term diet therapy with as there is no single diabetic or diabetes appropriate diet, but the recommended diet is an individual nutrition prescription based on assessment and finding in addition to the treatment of the patient. So medical nutrition therapy considers the usual eating habits and other lifestyle factors with strategic patient counseling that should identify the benefits of the plan, self-efficacy, obstacles, and lifestyle changes that the patient is willing to make. So these interventions will help reach the desired outcome in general. Also, using open-ended discussions and counseling will encourage the client to assess and determine a realistic self-management plan. And medical nutrition therapy should be offered in phases according to the patient comprehension and readiness. So screening for diabetes is outlined with the nutrition care process, including assessment, nutrition diagnosis, intervention that is followed by monitoring and evaluation. So monitoring for blood glucose, the medications, physical activity, education, behavior modification, and evaluation of cardiovascular and renal status are all relevant. In addition, prevention of complications is essential. And a diabetes educator is defined as a health professional who has mastered the core knowledge and skills with communication, counseling, and education. And the credentials of a certified diabetes educator is designated for professionals who have at least 1,000 hours of direct diabetes teaching and who have successfully completed an examination. So an advanced credential has been developed for registered dietitian, nurses, pharmacists who have advanced degree and meet experimental requirements, and it is known as BCADM. So some of the key concepts in diabetes management include glucose control. By having improved glycemic control, benefits the people with either type 1 or type 2 diabetes. As for every 1% reduction in results of A1C blood test, the risk of developing microvascular diabetic complications dropped by about 40%. Also, A1C is the primary target for glycemic control and should be monitored. And for glucose control, a more stringent glycemic goals should be followed to reduce the complications. Also, less intensive glycemic goals may be indicated in patients with severe or frequent hypoglycemia. So the postprandial glucose may be targeted if A1C levels or goals are not met despite reaching the preprandial glucose goals. So these goals should be individualized and lower goals may be reasonable based on the benefit risk assessment for the patient. So certain populations require special consideration according to the following guidelines. These include children, pregnant women, and elderly. So the preprandial, the bedtime, and the A1C levels are different according to age, as in those between the ages of 0 to 6, they will have higher risk and vulnerability of hypoglycemia. Therefore, their glycemic control should be less strict than the others. Also, for those between the ages of 7 and 12, the risk of hypoglycemia and relatively low risk of complication before puberty is more common. Therefore, they can have better control in these cases. And for adolescents and young adults, they can have a risk of severe hypoglycemia and developmental and psychological issues. Therefore, they will have lower goals that is reasonable to achieve without excessive hypoglycemic risk. And for adults, the peak of the postprandial Glucose 1 hour to 2 hours after the beginning of the meal is monitored. So the blood pressure control should also be monitored with the goal of having a blood pressure of 130/80 and restriction of sodium to 2,400 milligram will assist in the control of hypertension. So blood pressure control can reduce cardiovascular disease by approximately 30 to 50% in general, and can reduce the microvascular diseases of the eye, kidneys, and nerves by approximately 33%. So, in general, for every 10 mmHg reduction in the systolic blood pressure, the risk of any complications that is related to diabetes is reduced by 12%. So, the control of the blood levels is also important by improving the control of HDL, LDL, and triglyceride, which can reduce the cardiovascular complications by about 20 to 50%. Also, the goals include total cholesterol minus the HDL should be 130 milligram, and LDL should be 100, while triglyceride should be 150. So preventative care practice for the eyes, kidney, and feet include detecting and treating diabetic eye disease with laser therapy, which can reduce the development of severe vision loss by an estimation of 50 to 60%. So comprehensive foot care program can reduce amputation rate by about 45 to 85%. So preventative care for diabetes and kidney failure include detecting and treating early diabetic disease and kidney disease by lowering uh, the blood pressure, which can reduce and decline in the kidney function. So angiotensin converting enzyme inhibitors and angiotensin receptor blockers are most effective in reducing the decline in kidney function. So with protein intake greater than 20% of energy intake, there is an association with increased albumin excretion rate. Once albuminuria is present, reduced protein to 0.8 up to 1 is required. So there is evidence for benefit of renal function, glucose, lipids from weight maintenance and diet. Also, collaborative multidisciplinary teams should be recommended. And medical nutrition therapy provided by the registered dietitian should be followed. So it is also important to address culturally specific eating habits. For example, a recent study in South Dakota found that diet patterns after historical hunter-gathered type of diet provided better blood glucose control and lower circulating insulin level. So the same may be true for other high-risk groups, therefore should be followed. So some of the supplements that should be used include uh, various starches that doesn't have different glycemic responses, with first priority that should be given to the total amount of carbohydrate that are consumed rather than the source of carbohydrate itself. So if the use of glycemic index is proposed as a method of meal planning, then the dietitian should advise the conflicting evidence of effectiveness to these strategies. And for nutritive sweetness, these can also increase blood sugar levels with such as soft drinks and chocolate bars, in addition to sucrose, which is found in most sweetness of the sugars, and in corn syrups, molasses, dextrose, glucose, and maltose, all of which will have some effects on these factors. Also, intake of honey should be monitored in these patients. So, for the use of herbs and potential supplements, this include aloe vera. Studies in Japan found that phytosterols in aloe vera might play a role in the lowering of blood glucose levels, and further research is needed in this area. So for the alpha lipoic acid, this can also have some potential benefits as it has been found in the mitochondria and seen to have antioxidant properties that protect vitamin C. So antioxidant as well can from food should include good sources of beta carotene, vitamin C, and E. as well as bilberry, which contain acanthoses that can contribute to cellular damage and retina, with mild drowsiness and skin rash that have been noted. And for biotin, this can show preliminary evidence of being useful for controlling blood glucose values. Also, bitter melon can have or has been traditionally used as a remedy for lowering blood glucose values, and chromium enhances the use of insulin, but can have some skin allergies, renal toxicities, and altered iron and zinc absorption, which can develop. And there are no proven benefits if a patient is not deficient of these two vitamins. So with cinnamon, a dose of 1, 3, or 6 gram per capsules on a daily basis will lower the blood glucose levels in individuals with diabetes. So for essential oils from cinnamon, cumin, and oregano, they may enhance insulin sensitivity, but studies are still ongoing. Also, evening bromelain oil may prevent or limit the neuropathies due to gamma linolic acid, which is an essential fatty acid that is present in these cases. In addition, fenugreek may also lower the blood glucose, the triglyceride, and the cholesterol values, therefore should be used under close supervision to avoid any complications. In addition, for garlic, they may lower the blood glucose level if used in large amounts. More studies are still needed in this area. And for the ginseng, it can lower the blood glucose level, but it should be avoided with warfarin, aspirin, MAO inhibitors, caffeine, insulin, or other oral hypoglycemic medications. And for guar gum, it is a fiber that normalizes the moisture content of the stool and can absorb any excessive liquid in diarrhea and soften the stool in constipation and decrease the amount of cholesterol and glucose in general. Also, the Ginama silverates is a hypoglycemic herb that is highly potent and should only be used under doctor's supervision because it can change insulin requirement in these populations. In addition, magnesium is needed for hundreds of biochemical reactions as it can help in regulating the blood sugar values and lower the blood pressure. And some studies suggest that low magnesium level may worsen the blood glucose control in type 2 diabetes, and magnesium supplementation may help with insulin resistance, but we should avoid having high doses. And for turmeric, it can decrease the blood glucose level as it has hypoglycemic action of mode of action. And for Vandam, it can also lower the blood glucose levels and has been associated with cancer cell growth and can be toxic at therapeutic levels. And for vitamin B6, some studies can suggest that an adequate intake of vitamin B6 will help with both type 1 diabetes and type 2. And vitamin D supplementation of up to 2,000 international units on a daily basis in infants were found to be less likely to develop type 1 diabetes over the next 30 years. So there are many supplements that can help in managing diabetes, but should only be consumed under physician supervision and close monitoring to avoid any hypoglycemic or adverse reaction. We will be taking a break now for Salat al-Asr and then continue our discussion. After we have uh, the general terms about diabetes, its different types, and the appropriate approaches for the management, we will continue our discussion with some of the common complications of diabetes. So first of all, one of the more common diabetic complications is diabetic gastroparesis. It occurs in approximately 50% of all cases of diabetes with delayed gastric emptying in the absence of the mechanical obstruction. So diabetic gastroparesis is the result of ongoing damage to the nerves that are responsible for peristalsis and the normal motility. So the food that digests abnormally, slowly, or even in peristalsis is diminished so that it is difficult to match the insulin action to the digestion and absorption of the meals. So if food stays in the stomach for too long, then infection is possible. Also, the food can harden into a solid lump, and these bizarres can cause abdominal pain, nausea, and even blockage in the digestive tract. So hypoglycemia can occur if insulin is working and if food remains in the stomach for too long. So later on, insulin action is diminished and food will finally digest, therefore causing hyperglycemia. And problems that occur more often in type 1 diabetes than in type 2 diabetes. Therefore, having a strict glycemic control is a key factor. So a gastrostomy is rarely indicated, but a jejunostomy may be helpful in maintaining nutrition. And using prokinetic agents that are the best treatment option in this case, therefore should be followed. And gastric electrical stimulation may also be used to send out the brief low energy impulses to the stomach in order to decrease the nausea and vomiting. So the appropriate intervention in this case focus on the following objectives, including correcting the fluctuating in the blood glucose level through careful food and insulin management, also frequent blood glucose checks and monitoring for records. And for nausea and vomiting, restoring the volume and hydration will provide antiemetic agents generously in order to manage these symptoms. So to relieve these symptoms, pain, diarrhea, constipation, and even maintaining adequate nutritional status is required. Also differentiating from ketoacidosis, which has similar symptoms of nausea and vomiting, and preventing infection or bizarre formation from being accumulated in the ingestible. So for food and nutritional intervention, we should monitor the as carefully as possible to avoid these complications and the blood glucose fluctuations, which are common. We should also include about 200 to 240 grams of carbohydrate on a daily basis and should be spread out throughout the day. We should also use 2 to 3 carbohydrate servings per meal to ensure that the blood glucose levels remain constant. In addition, we should be consistent from day to day. So soft to liquid diet may be useful to prevent a delay in gastric emptying, and having 6 small meals may be better tolerated than large meals, with using low-fat diet to improve digestion and to improve stomach emptying in general. So, sitting up after meals and decreasing the overall fiber intake from meals or supplements is recommended. Also, oranges, broccoli, green beans, berries, figs, and fresh apples may be difficult to digest. Therefore, they should be taken in limited quantities. And if the patient is having dry mouth, we should add extra fluid and moisten foods with broth or even allowing sauces or gravies. And if nausea occurs, then cold food and low odor choices may be better tolerated. So, in severe problems, a percutaneous eugenestomy tube feeding can be indicated. It can also be temporarily used if needed to correct any associated malnutrition. Some of the common medications that are used in gastroparesis include prokinetics, such as Reglan, which may be given 30 minutes before the meal to increase the gastric contraction and to relax the pyloric sphincter. Also, for dry mouth, sleepiness, diarrhea, or nausea, these can all be possible associated side effects. In addition, imatazole is a nasal spray form of this medication and can be used in specific cases. And for metoclopramide prophylaxis, it should be used to reduce the gastric volume before an elective surgery is used or so unless the patient has a prolonged history of poor blood glucose control, this is unnecessary. And having rapid acting insulin should be injected with or after meals, and using SMPG to monitor the delayed absorption and glucose changes should be recommended. So insulin lispro is quite effective because it can start working shortly after the injection and it can help in controlling the blood glucose. So it may be necessary to take insulin more often and to take insulin after eating instead of before, and to also check for blood glucose. So if a liquid diet is used, then more insulin may be needed, but insulin pumps may be beneficial because insulin delivery rates can be programmed to the patient individually. So because there is a receptural relationship between the gastric emptying and ambient glucose concentration, so in this case, antiemetic may be used for vomiting, but we should monitor for specific side effects, and Zofran may cause constipation or headache in these cases, therefore should be avoided. So the erythromycin can improve the stomach emptying by increasing the contractions which move the food through the stomach. Also, side effects can include nausea, vomiting, diarrhea, abdominal cramp, and some of the GI-associated symptoms. So using antihistamine, which help to prevent nausea and vomiting, is recommended, but slight to moderate drowsiness and thickening of the bronchial secretion can develop. So methylium is also used to manage the upper GI problems, and side effects can include headache. For herbs and potential supplement, it shouldn't be used without discussing it first with the physician. But as we have mentioned, some have been proven to have a hypoglycemic impact, therefore should only be used under careful consideration. For example, aloe vera. Studies in Japan found that phytosterols in aloe vera might play a role in lowering the blood glucose levels, but further research is needed in this case. And for the alpha-lipoic acid, it has some potential benefit as it has been found in the mitochondria and seems to have some antioxidant properties that protect vitamin C, E, and glutathione. So some natural sources include red meat, yeast, potatoes, and spinach, and supplementation may provide protection against cataract, neuropathy, and diabetes, cardiovascular disease, but further research is needed. And for antioxidant, from food, it should include good source of beta-carotene, vitamin C, E, selenium, and zinc. And for nutrition education and counseling, we should discuss delayed digestion and absorption of food. We should also discuss the role of diet in maintaining weight and controlling discomfort. We should also emphasize on nutrient-dense food if they are taking or has been taking in poor amount. Also, blenderized food or smoothies may be well tolerated in these conditions. But for bizarre formation, it can occur after eating oranges, coconut, green beans, apples, and other green leafy vegetables. So we should discuss insulin management as appropriate with the patient and include information about SMPG and meal spacing throughout the day to ensure the best glucose control. In addition, we should advise the doctor if the blood glucose level are 200 milligram per deciliter or higher. And in regard to patient education for foodborne illnesses, if the patient is using home tube feeding, we should teach them on appropriate sanitation and food handling procedures. Another common diabetes complication is diabetic ketoacidosis. As ketone in the urine means that the body is burning fat to get energy because glucose is not available. So the lack of insulin can lead to gluconeogenesis in the liver, then glucose will spill into the urine and causes an osmotic diuresis with dehydration. So free fatty acids are released from the adipose tissue and are converted into acidic ketones. This is conducted by the liver. So large amount of ketones in the serum and urine can be dangerous. And for diabetic ketoacidosis, it is considered as a classical metabolic acidosis, which is a medical emergency that accounts for more than 100,000 hospital admissions yearly in the US alone. So a patient with a low serum potassium level should be assumed to have potentially life-threatening crisis. So causes of DKA include not getting enough insulin from missed injections, also alkaline reserves that are depleted by too little insulin, flu or colds or even fever, and any condition that causes stress on the body, such as pregnancy, trauma, or myocardial infarction and infections. So the triad of uncontrolled hyperglycemia, metabolic acidosis, and increased total body ketone concentration are characterized of DKA. So these metabolic derangements can result from the combination of absolute or relative insulin deficiency and increased level of the counter-regulatory hormones of glucagon, or even catecholamine, cortisol, and growth hormone. So the differences or diagnostic criteria between DKA and the hyperosmolar hyperglycemic status are according to the plasma glucose, the arterial pH, serum bicarbonate, urine ketone, and serum ketones, and effective serum osmolarity with mental status. So DKA is primarily seen in patients with type 1 diabetes, but few type 1 diabetic patients can present with DKA on the initial diagnosis. So in children, DKA is the leading cause of hospitalization and is a cause of cerebral edema, which may lead thereafter to death if it was untreated. So DKA can also occur in type 2 diabetes, usually from UTI, trauma, stress, pregnancy, surgery, or even myocardial infarction. So in these cases, inflammatory processes may play a role, and both DKA and its treatment can produce varying degrees of immunological stress. And all individuals with DKA should be tested for hyperthyroidism, and we should use standardized written guidelines that have merit recommendations. So for the intervention, the objectives are to correct the high blood glucose levels by giving more insulin with frequent blood glucose and ketone monitoring that is necessary. Also, we should note that urine ketones lag behind the serum ketone because it can take time to empty the bladder where they can have accumulated and been stored. We should also replace fluids and electrolytes that are lost through excessive urination and vomiting. We should also promote return to wellness after poor health for several days, and we should evaluate precipitating factors such as surgery, trauma, UTI, pneumonia, or influenza. In addition, we should monitor frequently to prevent the reoccurrence of DKA. More importantly, we should prevent complications such as shock, arterial thrombosis, renal failure, or cerebral edema. So there remain a significant problem with high mortality rate due to the cerebral edema with the DKA, and young children are especially vulnerable and may slip into a coma. So for chronically high fasting glucose level, we should adjust the evening, intermediate, or long-acting insulin doses or the timing as well. So the diagnostic criteria for hyperosmolar hyperglycemic state and DKA are based on the plasma glucose, arterial pH, serum bicarbonate, ketones in the urine and serum, and the serum osmolarity with the mental status. So for food and the nutrition, if the patient is comatose, then intravenous insulin, electrolyte, and fluid are used. And having a nasogastric tube may be placed to prevent aspiration during feeding, where if the patient is alert and oriented, we should offer plenty of fluid orally. And as treatment progresses, a 5% glucose solution is usually given as glucosuria and hyperglycemia subsides. So if glucosuria and hyperglycemia doesn't decrease, then we should try tea and salty broth, with later on trying fruit juices and liquids that are high in potassium and can be given. So the resolution of DKA will lead to the ability to tolerate oral nutrition and fluid, normalization of blood acidity, and absence of ketones in the blood. And once this has been achieved, then insulin may be switched to the usual regimen. So some of the common drugs that are used include insulin, of course, and fluid that are usually given intravenously to decrease the blood glucose by 50 to 75 milligram per deciliter. Also, guidelines may recommend a bolus, initially large doses of insulin, and it should be higher if the body weight or if the intake is higher than 3.3. So regular and glucose insulin are equally effective during the acute treatment of DKA, and having a basal bolus regimen with glargine and glucosamine is safer than NPH and the regular insulin after the resolution of DKA. So dextrose insulin is given once the plasma glucose decreases to avoid any accidental hypoglycemia. So potassium, phosphate, and magnesium level can be low in these cases, and having bicarbonate therapy is needed only on rare occasions, but intravenous antibiotic therapy will be needed where there is sepsis, and atypical antipsychotic thiazide diuretics and corticosteroids can lead to DKA if the patient is not carefully monitored. So for herbs and potential supplements, as we mentioned, it shouldn't be used without discussing it first with the physician, and we should ask the patient about them directly to avoid any medication and herbs interaction. While for nutrition, education, counseling, and care management, we should explain the demands for more insulin during insulin illnesses and infections. We should also use diabetes records that may be useful if there are episodes of high blood glucose, which are frequent, and we should never exercise when there are ketones present. So all of these steps should be educated to the patient in order to have the best outcome on their diabetes control. And because every episode of DKA will imply the breakdown in clinical communication, therefore appropriate diabetes education should be reinforced. And education of the patient and their social environment to promote frequent testing, especially during sick days, and to also lower their glucose level, as well as to recognize the early symptoms of hyperglycemia and DKA is of paramount importance in preventing the development of severe DKA. So when a strict control through insulin is administered, then weight gain is common, and insulin omission and reduction, which are eating disorder symptoms that are unique to diabetes, are often associated with increased risk of DKA. So attention to this disorder is important in overall treatment planning and management, while the biggest risk of insulin pump therapy is DKA, since no long-acting insulin is being used. So any interruption to insulin delivery or pump malfunctioning can cause DKA, and to prevent this reaction, we should monitor the blood glucose on a regular basis and have insulin pump user needing to check often to see that insulin is still flowing through the tubing as required. While for patient education in foodborne illnesses, if the patient was using home tube feeding, then we should teach them about appropriate sanitation and food handling procedures. Another common diabetic complication is hyperosmolar hyperglycemic state. So diabetic HHS is a life-threatening emergency with marked elevation of the blood glucose, hyperosmolarity, and minimal or no ketosis. So this condition is preventable if the blood glucose is monitored on a regular basis in order to correct the elevating levels before any problem occurs. So the condition occurs in patients who are older than 70 years with type 2 diabetes and also have profound dehydration as a precipitating factor. So if this was recognized early, then it can frequently be treated in the outpatient setting if the patient can take fluid. And sometimes DKA is considered the first time that diabetes is diagnosed, and identification with treatment of the underlying and precipitating cause of HHS are absolutely essential for the best care of the patient. So the predisposing factor for this syndrome include long-term uncontrolled hyperglycemia, pancreatic disease, infections or sepsis, also stroke, surgery, or extensive burns. In addition to this, renal or CVD, corticosteroid use, diuretic, extensive total parenteral nutrition, or having dialysis with underlying poor compliance to medications, infections, or cocaine abuse are the most common causes for these conditions. Where in children, corticosteroid use and gastroenteritis are common causes, but the mortality rate is high in this condition at a rate of 10 to 20% of all cases. And area of future research include prospective randomization studies to determine the pathophysiological mechanism for the absence of ketosis in this condition to investigate the reason for the elevated pro-inflammatory cytokines and any cardiovascular risk factors. While for the intervention, the objectives focus on correcting dehydration, shock, and cardiac arrhythmia, in addition to reducing the elevated blood glucose level with isotonic saline, then hypotonic saline along with insulin. But we should also monitor the fluid status and replace the deficiencies, which may be 10 to 20% of the total body weight. So this may require up to 9 liters in 48 hours to be given to the patient. Therefore, this should be carefully assessed to ensure that the patient has the best fluid intake. In addition, we should prevent future crises by appropriate DSME and regular monitoring of the blood glucose. And we should prevent acute renal failure, which could result from prolonged hypovolemia. And for food and nutritional intervention, we should offer fluid replacement, often in a rate of 1 liter per an hour until the volume is restored. And as we mentioned, 9 up to 12 liter may be needed depending on the condition. And patient is likely to be on an MPO status during the crisis or perhaps tube feeding during the comatose status. So as appropriate, the intake may be progressed gradually to a balanced diet and controlling for caloric intake as needed. We should also correct the electrolyte deficiencies, the potassium or magnesium that may be needed, and the reported sodium levels should be corrected when the patient's glucose level is markedly elevated. So in these circumstances, having extracellular fluid osmolarity rises and exceeds that of the intracellular fluid since the glucose penetrates the cell membrane slowly in the absence of insulin, therefore resulting in the movement of water out of the cells into the extracellular fluid. So type of fluids administered will depend on the corrected serum sodium level, also the calculated using the following formula of the measured sodium, assessing the serum glucose over 100 and multiplied by 1.6. So a renal diet plan may be needed if renal failure is identified in these patients. So the common medications used in this case include this includes insulin that is needed to normalize the blood glucose levels. So insulin is needed to normalize the blood glucose levels, and infusions will be needed until full rehydration is completed. So DKA and HHS are associated with elevation of the pro-inflammatory cytokines, and insulin therapy will provide a strong anti-inflammatory effect. So potassium replacements may be needed, but we should monitor carefully, and having antibiotic therapy may be needed in cases of underlying infections. So drugs that may precipitate the HHS syndrome include diuretics, beta blocker, clozapine, olozapine, H2 blockers, and cocaine. For herbs and potential supplements, they shouldn't be used without discussing it first with the physician. And for the nutrition education and counseling, we should discuss, where possible, any predisposing factors, how to avoid future incidents, and blood glucose monitoring at all times for these patients. So, carbohydrate controlled diet may be beneficial if the patient can comprehend the approach. Also, family intervention may be required to ensure the best outcome for the patient's health. We should also discuss any possible neglect or abuse if it was suspected. In addition to this, continuous management of the fluid, electrolyte, and glucose disturbances is necessary until the problem is resolved. We should also provide diabetes teaching to prevent reoccurrence of these conditions. In addition, adjusting insulin or oral hypoglycemic therapy on the basis of the insulin requirement once the serum glucose levels are stable. So coordinating a home visit from nursing or dietitian if needed to evaluate the inadequate access to water in order to ensure the best outcome for the patient. And for patient education in foodborne illnesses, if the patient was using home tube feeding, then we should teach them appropriate sanitation and food handling procedure. We will be taking a break now and then continue our discussion with other public health approaches for management of diabetes.
Metabolic disorders of multiple etiology and characterized by chronic hyperglycemia with disturbance in the carbohydrate protein metabolism are resulting from defects in insulin secretion, insulin action, or even both. So, diabetes is a chronic condition that is characterized by raised plasma glucose level diabetes, therefore resulting from the body inability to produce or use insulin properly, therefore resulting in high level of blood sugar. In type 2 diabetes, it is caused by a combination of insulin resistance and some degree of insulin deficiency. And in type 1 diabetes, the body produces no insulin at all, and more than 80% of the recognized and in type 1, the body will produce no insulin more than 80% of the recognized diabetes, that is type 1, and most of the remainder is type 1. So the WHO defined diabetes as fasting blood glucose more than 126 on one single occasion, or around the blood glucose of 200 or more on two or more occasions. So the magnitude of the problem is that the number of people with diabetes will nearly double within the first quarter of this millennium. And the WHO estimates the prevalence of diabetes for all age groups worldwide that was estimated to be about 3% in 2000 and 4.5% in 2023. So the estimated raise in the numbers from 171 million up to 366 million in 2023, and about 150% raise in developing countries by 2023. And the numbers of deaths are also expected to increase in a previous amount. So prevalence in several parts of the countries is increasing in general. And why type 2 diabetes is more prevalent, or its prevalence is increasing, this is due to aging of the population, increased incidence due to urbanization, especially in developing countries, relating to more sedentary lifestyle, food consumption patterns, and more food with high fat content and more refined carbohydrates. So the direct cause of diabetes is that individuals and their families will include the medical care, the medication, insulin, and other supplies, while the direct cost to the healthcare sector include hospital services, physician services, and any other related. So overall, the direct healthcare cost of diabetes can range from 3% to 15% of the annual healthcare cost, depending on local diabetes prevalence and treatment available. While the indirect costs include absence, disability, premature retirement, or mortality that can cause loss of productivity. So estimating the cause of the society of this loss of productivity is not easy, but pain, anxiety, inconvenience, and other factors can decrease the quality of life, which are intangible costs, which are just as heavy. So facts on preventing diabetes is that it has heavy social and economic cost of type 2 diabetes, including its role in other diseases such as heart disease and stroke, with the mean that primary prevention must be a priority. Also, prediabetes can prevent the development of type 2 diabetes by making changes in their lifestyle with effective prevention that also mean more cost-effective healthcare. And the primary prevention will protect the susceptible individuals from developing diabetes. It has an impact by reducing or delaying both the need for diabetes of the care and also to treat diabetes complications. So the secondary prevention include early detection, prevention, and the treatment with appropriate action taken at the right time that is beneficial in terms of the quality of life and is cost effective, especially if it can prevent hospital admission. So primary prevention focused on weight loss, physical activity, and smoking cessation. While the lifestyle changes can prevent diabetes, weight loss is accompanied by considerable lowering of the risk factors of diabetes. So physical activity and diabetes prevention and smoking that predispose to type 2 diabetes. While major issues to consider include policy and advocacy at national level, capacity building, resources, monitoring and evaluation, also diabetes registries and information systems. So weight loss is accompanied by considerable lowering of the risk of diabetes as BMI, which is the obesity in adults that assist using body mass index. The higher the body mass, then the higher the mortality or the morbidity risk to become. And the risk of diabetes can increase about 15-fold as the BMI increases to 23 kg per meter square up to 35. While for the waist circumference, the BMI doesn't indicate the distribution of body fat, and waist circumference is therefore also used as a measure of obesity and associated health risks. So, treatment of obesity will prevent illness development in individuals at risk and also improve quality of life and prevent late complications in those already affected. So, in recent years, attention has been increasingly focusing on the incidence of central obesity, which has been found to strongly predict the risk of type 2 diabetes and metabolic syndrome. While physical activity decreases insulin resistance and can aid both in the prevention and the managing of the disease. So physical activity has an insulin-like effect. It can help in lowering the blood sugar levels, and epidemiological studies suggest that the physical activity can reduce the risk of non-insulin dependent diabetes up to 50%. While as smoking predisposed to type 2 diabetes, studies have shown correlation between smoking and the risk of developing type 2 diabetes. While the risk is dose dependent, the longer So, as we were saying, studies have shown a correlation between smoking and the risk of developing type 2 diabetes. So, this is dose dependent. The longer the person smokes, then the higher the risk is for that type 2 diabetes. Therefore, recommendation is that change will come more easily if everyone is involved, and the prevention of diabetes can be on different level on the individual, the community, and the governmental with the national level. So the recommendations are that the government should work up and reduce the health inequalities, safety and making of the safety for walking and exercise and activities in general. So parents of overweight children should be helped to take the responsibility and encourage healthy eating and physical activity. And the classification of type 1 diabetes is that it lacks insulin, autoimmune, and usually in children. But type 2 is insulin resistant and has some lifestyle factor and usually developed during adulthood. While gestational diabetes is also insulin resistant that is during pregnancy and can have risk for both the mother and the child. So this is the prevalence of diabetes worldwide in 2000, and the world average was about 30%. But between 23 and since 2000, this has widely increased. And the prevalence, as you can see, was in 2013 even higher than the projected levels. So people with diabetes would require at least 2 to 3 times the healthcare resources compared to the people who don't have diabetes. So diabetes care may account for up to 15% of the national healthcare budget, with risk of tuberculosis that is 3 times higher among people with diabetes. So these are the estimation that was based in early 2015, and these are also the estimated deaths in 2015. So the proportion of diabetes-related death in people under 60 of all dying due to diabetes is found to be at far higher risk. And for the age standardized prevalence of diabetes in adults aged 25 and more, several factors will found to be associated according to the WHO. So why are we projecting these levels? The primary driver is the rapid epidemiological transition and associated with the changes in dietary pattern, decreased physical activity, as evidence from higher prevalence of diabetes in the urban population has indicated. While risk factors include preventable risk factors under most NCDs, and most of which are strongly associated and causally linked with four particular behaviors. Also, tobacco use, physical inactivity, unhealthy diet, and harmful use of substance. So there are four key metabolic physiological changes, including raised blood pressure, overweight and obesity, hyperglycemia, and hyperlipidemia, all of which are risk factors that lead to diabetes. So the attributable death include the risk factors globally of raised blood pressure of 13%, tobacco use of about 9%, raised blood glucose of 6%, physical inactivity in about 6%, and overweight and obesity in 5%. So the insulin deficiency can be complete or partial due to pancreatic disorders with insulin synthesis abnormality, destruction of beta cells, or autoimmune reaction. These are all epidemiological determinants. And the modifiable risk factor as physical inactivity, diet that include high saturated fat, salt intake, low fruit and vegetable intake, and low dietary fiber intake. While the non-modifiable factors include age, gender, genetic factor, ethnicity, and family history. And the clinical feature are that mostly are asymptomatic but can have polydipsia, polyuria, and polyphagia, with blood sugar testing, fasting, and postprandial after 75-gram glucose load. So the diagnostic values are different between type 1 and type 2 diabetes, and some of the complications include macrovascular, such as coronary heart disease, and are the most common cause of death. Also, the healthy nutritional habits should be focused as primary prevention with promoting physical activity, maintaining ideal body weight, and creating awareness of lifestyle modification and enabling environmental factors. We should also screen the targeted population who are asymptomatic based on the following criteria: who are aged more than 30, are overweight, also the overweight also screening the high-risk population. So family history, symptoms of hypoglycemia, and steroid use. Also self-care. And all of these steps can be targeted as appropriate population public health approaches for diabetes management and prevention.
Uh, it's my pleasure to be with you today in this course about diabetes mellitus, and I hope that the previous lecture was interesting for all of you. And to continue the journey of diabetes mellitus, my topic is talking about one of important subject in diabetes field, which is diabetes emergency. And I will focus on diabetes ketoacidosis. So my major talk will be about diabetes ketoacidosis. What are the causes? What are the pathophysiology? What is the pathophysiology? Symptom signs, diagnosis, and finally how to treat. So thanks for the previous speakers, and I hope we will enjoy the remaining of the day of diabetes course. Let's share my slides. I hope that the voice is okay and slides are okay. So before we go further or deep in the topic, I invite all of you to join DMOS Twitter account. Actually, it's a scientific account about diabetes and endocrinology. If you are interested in this field, please follow this account. It's actually related to any review, update, articles related to diabetes and endocrinology. So please, if you are interested, you can follow this scientific account, ENDODMOS. So let's focus on diabetes ketoacidosis. As I told you before, part of diabetes care and management, you know, how are the acute complications? You have to know the acute complications. And the acute complications here is related to uh, uh, either type 1 or type 2. And in type 1, usually we are seeing diabetes ketoacidosis, and in type 2, HHS or hyperosmolar non-ketotic status is commonly seen. So, nursing and staff rules identifying incident, clinical treatment, and protocol education of patient and staff. Who are the patients at risk to develop diabetes ketoacidosis? Patients who are insulin requiring, patients on polypharmacy using many medications, elderly patient, very young patient, substance abusers, cognitive deficiency patients. So if you find any of these risk factors, you will expect abnormal balance in the blood glucose and hyperglycemia, definitely. In general, you know, the symptoms of hyperglycemia, including polyuria, hunger, increased urination, fatigue, vision changes, and vague malaise. And acute hyperglycemia leading to crisis, low level of circulating insulin, high level of counter-regulatory hormones observed. And just a quick question for the audience, just to pay your attention. I need your answer in the chat box if possible. And think about it. Patient has normal blood glucose, and you still diagnose diabetes ketoacidosis. So this statement is true or false? I need your input down in the chat box, please. So I see here many answers with yes, but still we have some B's, and the correct answer, let's give you some more time. I think there is good participation from your side before I give you the correct answer. Okay, maybe the majority were going with true and some going with false. Actually, it is a correct statement. Maybe sometimes in special situations, like for example, if the patient is pregnant, if the patient using some oral hypoglycemic agents like SGLT2 inhibitors drugs, in this situation, the blood glucose may be down in will be normal in the blood but still you can diagnose diabetes ketoacidosis by doing the blood gas test. So I will not go further, but yes, maybe sometimes you can diagnose diabetes ketoacidosis with normal glycemia. So what are the precipitating factors to develop DKA? Missing dose or omission of insulin, acute major illness such as myocardial infarction, cerebrovascular accident, sepsis or pancreatitis, using of some drugs like steroid, high dose of thiazide diuretics, sympathomimetic agents, and atypical antipsychotic agents. Use of some oral hypoglycemic agents under the group of SGLT2 inhibitors, empagliflozin, dapagliflozin, and canagliflozin, and psychological problems and cocaine abuse. Insulin pump malfunction, so all of these are precipitating factors. DKA again is an acute severe metabolic complication of diabetes mellitus. It is characterized by ketoacidosis and hyperglycemia. It is more common to see DKA in which type? Just a quick question for the audience. A, type 1, B, type 2, or gestational diabetes mellitus C? I need your answer, please. So I think yes, majority or almost all of you going with the correct answer. It's going with the type A. Good. Type 1, sorry, which is the answer, the first answer, A. In general, as you know, symptoms related to diabetes emergency, we'll try to talk about them. I will not focus on the hyperosmolar non-ketotic status. I think this is a topic for a colleague. But here in my presentation, I will focus on DKA and diabetes ketoacidosis onset in 24 hours or less, dehydration, maybe observed tachycardia, hypotension, acetone breathe, cosmal respiration or breathing, mental status range from alert to stuporous. What about the differences in lab value? Just to have an idea, the DKA usually plasma glucose is high, 250 and above, but it is sky high in plasma glucose with HHS 600 plus. Arterial pH 7.3 or less, but it is 7.3 and above in HHS. Sodium bicarbonate is low because we have metabolic acidosis in DKA, but sodium bicarb above 15 in HHS. Ketonuria strongly positive and negative to small ketonuria in HHS. DKA has positive serum ketone, serum osmolality may be variable, and an ion gap usually high above 10 or 12. The serum osmolality usually above 320 in patient with high hyperosmolar non-ketotic status and low anion gap. Here is quick video about pathophysiology of DKA before we go further. Please concentrate.
In this video, we're going to take a look at the pathophysiology that leads to diabetic ketoacidosis. To do this, we're going to use some basic cartoons, not because I think you're children, but because they're a useful way to produce some memorable visual images to help us get to grips with this topic. In this video, we're going to talk about insulin, glucose, glucagon, and ketones. Diabetic ketoacidosis, or DKA, results from the body having insufficient insulin available to meet its needs. This is nearly always a result of type 1 diabetes. Tim normally manages his type 1 diabetes well. However, he has an important meeting at work today and is feeling distracted. Unfortunately, he left home without remembering to take his insulin. To understand why this is a problem for Tim, we need to have an understanding of the roles insulin performs in the body and what will happen if these roles aren't performed. The glucose we absorb into our blood from our diets is an important source of energy for our cells, but glucose can't pass into a cell without help. We need insulin to interact with the cell membrane first, making it permeable to the glucose, which can then be broken down for energy. As a sufferer of type 1 diabetes, Tim's pancreas can no longer produce insulin. As he forgot to take his insulin this morning, the glucose that he absorbed into his body at breakfast can't be used by his cells. Normally, any excess blood glucose is put into storage for later use. Insulin is once again the hormone that regulates this process. High insulin levels promote the uptake of glucose into the liver, fat, and muscle cells. As Tim's blood insulin levels reduce, this process slows and then stops. Glucose is not being used for energy and is not being taken into storage. With nowhere to go, glucose begins to accumulate in Tim's blood. If he was to check his blood sugar now, he would see one of the first symptoms of DKA, an elevated blood glucose reading. When blood glucose levels become low, some of the stored glucose is released. This process is regulated by the hormone glucagon. Like insulin, glucagon is secreted by the pancreas, but rather than promoting the storage of blood glucose, it has the opposite effect. When glucagon interacts with muscle, liver, and fat cells, it stimulates them to release some of their stored glucose. The secretion of glucagon is regulated by insulin. High insulin levels inhibit the release of glucagon from the pancreas, while lower insulin levels allow for some glucagon to be secreted into the blood. Tim's blood insulin levels are now very low. As the release of glucagon is now not being inhibited at all, this leads to a lot being secreted from the pancreas. As a result, glucagon is stimulating large quantities of the body's stored glucose supplies to be released into his blood. Tim's blood glucose levels are rising even higher. Tim has arrived at work and is starting to realise that something isn't quite right. He is feeling thirsty, very thirsty in fact, and is needing to constantly drink water. He is also feeling a constant need to urinate. Did he remember to take his insulin this morning? He can't quite remember. He is feeling thirsty as a result of his high blood glucose levels. There is now so much glucose in his blood that it is beginning to have an osmotic effect on his body. By this we mean that the fluid in his cells is being drawn out towards the high concentrations of glucose. This fluid is then leaving the body via the kidneys, leading to Tim to suffer from another symptom of DKA, increased urination. As Tim loses fluid, he is of course becoming hypovolemic and thirsty. If he doesn't manage to drink enough water to replace this loss, then he will start to become hypertensive. He will also become tachycardic as his heart beats faster in an attempt to improve his cardiac output. So far, we have ignored a potentially big problem for Tim. Without insulin, the cells of his body are not getting the glucose they need for fuel. If the cells can't make use of the available glucose, then they will need an alternative. Luckily, just such an alternative is available. The high levels of glucagon signal the body's fat cells to release fatty acids into the blood. The fatty acids are then taken into the liver, where they're used to produce ketones. Much like glucose, ketones can be used as a source of fuel for cellular metabolism. Unlike glucose, however, they can enter a cell without the help of insulin. Ketones are now providing Tim's brain with enough energy to function. However, unfortunately for Tim, ketones have a significant side effect. They are acidic. A healthy individual can easily buffer the acidic effects of small quantities of ketones in the blood. But for Tim, the high levels of glucagon have led to the production of a lot of ketones. more than his body can handle. Tim's work colleagues are starting to become pretty concerned about him. He's shivering and breathing rapidly. When he tries to stand, he feels lightheaded, and he's becoming a little confused. If we were to check his pulse, we would find it has started to feel a little irregular. Tim is suffering the effects of a metabolic acidosis. His peripheral blood vessels are responding to the acidosis by dilating. This will reduce vascular resistance within his body and cause his blood pressure to become even lower. The combination of hypovolemia, resulting from the osmotic effects of high glucose levels in the blood, and the reduced vascular resistance, resulting from the peripheral vasodilation, has the potential to lead to a life-threatening degree of hypertension. The peripheral vasodilation is also causing more blood to flow to Tim's skin, where it loses heat. If Tim is not kept warm, he will start to become hypothermic. A side effect of Tim's high urine output is his body losing electrolytes, including potassium, with the urine. Tim's potassium levels are starting to become dangerously low, and the electrical conduction of his heart is starting to be affected, which is leading to his irregular heart rate. This is all looking pretty bad for Tim. His blood pressure is getting so low that he will soon begin to suffer from shock. He's becoming hypothermic, and he's beginning to suffer from a potentially life-threatening heart dysrhythmia. If these complications don't finish him off, then eventually the acidosis will begin to inhibit the effective functioning of his body's enzymes. This too can be fatal, as it will dramatically inhibit the function of the body's cells, including the brain cells. Luckily, his colleagues have called an ambulance, and Tim's off to hospital.
So I hope it was interesting and helpful to understand the pathophysiology of the diabetes ketoacidosis. As we mentioned before, it's a complicated pathophysiology, so I hope that it was helpful to understand the pathophysiology of DKA. Let's go further now. This is a very important differentiation between many categories of diabetes ketoacidosis. We have mild, moderate, and severe. I will not focus on HHS as we mentioned before, but the plasma glucose will be 200 and above in all DKA categories. Plasma arterial pH 7.25 to 7.3 in mild, and will be between 7 to 7.24 in moderate, less than 7 in severe. Sodium bicarbonate 15 to 18 in mild, 10 to 15 in moderate, less than 10 in severe. Urine ketones is positive, of course, in the cases of all categories. Serum ketones, again, the same issue. Serum ketones of beta hydroxybutyrate, hydroxybutyrate will be definitely high in severe cases. Moderate elevation 4 to 8 in moderate DKA, and mild 3 to 4 millimole per liter. And what about the osmolality will be variable, but it is of course not clearly very high in like HHS for above 320. And anion gap usually above 12 in severe and moderate cases, and in 10 maybe and above 10 in mild cases. And definitely there is a different alternation or alteration in the sensorium of mental status in the whole in the severe and moderate cases, and usually they are alert in mild cases. Classification of diabetes ketoacidosis, again, depending on the lab. I will not repeat here myself, just to know that there are many categories or many items to be measured before you classify your DKA. What is the current treatment of diabetes ketoacidosis? Very critical point here. HHS, as you know from my colleague topic, require hospital admission for intensive hydration and glucose management. In DKA, home intervention to prevent progression, hydration with non-caloric and caloric fluid, insulin correction doses, close monitoring of glucose and urine, hospitalization for ketones, moderate or disease progression. What about the replacement of fluid loss, correction of hyperglycemia, metabolic acidosis, replacement of electrolyte loss, detection and treatment of precipitating causes? In any case of DKA, keep these 4 items in your mind. You have to start with fluid. If it is possible to start fluid replacement at home or before hospitalization, it will play a major role. So fluid is number 1 therapeutic intervention in cases of DKA. Again, correction of hyperglycemia with insulin will be important. Sometimes in mild cases, maybe subcutaneous insulin be used, but in definitely more dangerous status, using of IV or intravenous insulin is important, or not important, actually, it is a critical or the choice in these situations. And definitely you have to look for the electrolytes, like for example, hypokalemia that's observed, and to correct these electrolytes with treat the underlying cause. For example, if the patient has infection, give antibiotic. If the patient has whatever the underlying cause, I mean, you have to correct. So what are the markers for the severity and know that these patients are severely sick and they need a critical care unit management or ICU? If the Glasgow Coma scale in neurological examination less than 12, if we have the severe low pH less than 7.5, if bicarbonate less than 5, if the potassium less than 3.3 or high above 6, if the systolic blood pressure less than 90, saturation less than 92 in room air, and pulse rate more than 100 or less than 60 beat per minute, urine output less than 0.5 ml per kg per hour, or evidence of acute kidney injury. So please, if you have these issues or these characteristic point, you have to classify your patient with severe ICU, and management in critical care unit is mandatory. So what is the immediate management? You have to be safe about intact airway, breathing and circulation, cardiac monitoring connection, urinary catheterization connection. Consider central venous pressure if needed in severe cases, nasogastric tube if there is necessary situations. What about the continuous monitoring needed in critical care unit in cases of DKA? Vital signs hourly, cardiac monitoring attachment, urine output again. So just a quick question for the audience to pay your attention. Which insulin type is used in infusion set during emergencies related, of course, to diabetes? We will use A, glargine insulin. You will use B, regular insulin. You will use C, detemir. Please give your answer down in the chat box and then we can discuss. I will give you a few seconds. So let's review together your answers. B, some of you thinks A, B again. Majority going with the correct answer, which is correct answer B, yes, regular. So either choose an infusion pump, a rapid-acting insulin, or regular insulin. Don't use long-acting insulin like glargine and detemir. So please, regular insulin is the used insulin in these situations. Let's move further now and talk about the protocol of management of adults patient with DKA. As you see here, we have a long algorithm while we are dealing with DKA. So we'll try to focus on the IV fluid in the beginning, followed by electrolyte, we can say correction, giving hyperglycemia treatment with insulin, and assess need for bicarbonate sometimes. If we talk about IV fluid, determine volume status, severe hypovolemia, need normal saline infusion 1 liter per hour, rate. If the patient with mild hypovolemia, evaluate corrected serum sodium, determine hydration status, and looking for the sodium level. If it is high or normal, maybe choosing half normal saline fluid at rate of 250 to 500 ml per hour is your choice. If the sodium is low, maybe you can go with normal saline. And then when serum glucose reach 200 down, maybe you can change to 5% dextrose with half normal saline at rate of 150 to 250 ml per hour. And after that, you have to check electrolytes, BUN, venous, pH, creatinine, glucose every 2 hours until patient is stable. So if patient has, for example, cardiogenic shock, hemodynamic monitoring with using of ionotropic support is indicated. Let's move further now and talk about the potassium replacement. A very important statement is establish adequate renal function is very important. And please, if the serum potassium less than 3.3, hold insulin and give 20 to 40 milliequivalent potassium per hour until potassium is corrected above 3.3. If the serum potassium is 3.3 to 5.3, give 20 to 30 milliequivalent of potassium in each liter of IV fluid to keep serum potassium between 4 to 5. If the serum potassium is more than 5.3, don't give potassium, but check serum potassium every 2 hours. Let's move now and talk about the role of intravenous insulin. As we mentioned before, in severe cases, insulin with rate of 0.1 unit per kg IV bolus started, followed by infusion 0.1 unit per kg per hour continuously. But again, subcutaneous route may be used in mild cases, rapid-acting insulin 0.3 unit per kg, then 0.1 unit per kg 1 hour later, followed by rapid-acting insulin 0.2 unit per kg subcutaneously every 2 hours. Then, if the serum glucose does not fall by 50 to 70 milligram per deciliter in the first hour, double IV or subcutaneous insulin bolus. When serum glucose reach 200 milligram per deciliter, reduce regular insulin infusion to 0.02 to 2.05 unit per kg per hour intravenously, or give rapid-acting insulin 0.1 unit per kg subcutaneous every 2 hours. Keep serum glucose between 150 and 200 until resolution of DKA. Definitely, checking the electrolytes, BUN, and following the after resolution of DKA, and when patient is able to eat, initiate subcutaneous insulin started by basal, and continue IV insulin infusion for 2 to 4 hours after subcutaneous insulin begin to ensure adequate plasma insulin level. In insulin naive patients, start at 0.5 to 0.8 unit per kg body weight per day and adjust insulin if needed. What about the bicarbonate rule? Should we give bicarbonate in all cases of DKA or in selected patients? So these are the this is the answer. If pH less than 6.9, dilute sodium bicarbonate 100 millimole in 400 ml water with 20 milliequivalent KCl, infuse over 2 hours. But if it is more than 6.9, no need for bicarb. Repeat sodium bicarbonate administration every 2 hours until pH more than 7. So please, not all cases, unfortunately, in the clinical practice, we are observing a lot of clinicians using bicarb, even from emergency room, with no clear indication, with no in mild cases. Please keep it with this indication, 6.9 pH and less, and in some guidelines giving the bicarbonate less than 5, maybe another indication. How to know that the patient has resolved DKA? First sign to have normalization in the plasma glucose less than 250, 200 between 200 to 250. See the serum bicarbonate start to be corrected above 15. Venous blood pH started to be more than 7.3, again corrected. Anion gap less than 12. So all of these are important signs, and in the clinical status, patient will be able to eat and drink. Definitely, this is another good sign. This is just to show you the correlation between estimated blood glucose and the hemoglobin A1C. If patients come to you with A1C of 10, you give the estimation of estimated average blood glucose is 240. Usually the range between 293 to 282. Maybe the other A1C with corresponding blood glucose average is observed. Again, when to check blood glucose, what is the goal of fasting blood glucose after resolution of DKA if the patient discharged? Keep in your mind that the fasting blood glucose in outpatient setting will be 80 to 130, postprandial 2 hours less than 180, bedtime between 90 to 150, A1C as mentioned in most of the cases less than 7. I have a quick video again for all of you to summarize DKA, and please concentrate on this video. I hope that it will be good for all of you.
Hey guys, Nurse Mike here, and welcome to SimpleNursing.com. Now, before we get today's lecture started, please remember to access your free quiz and preview our cool, nifty new study guides, not here on YouTube. Click the link right up here at any time during this video. All right, guys, let's begin. So how do you tell the difference between DKA and HHNS? Well, DKA is more common in type 1 diabetes and HHNS for type 2. So think which letter comes first in the alphabet. Well, guys, D comes first, so it's type 1, and H comes second, so that's how you know it's type 2. Now, what is DKA? Well, guys, let the name help you. diabetic ketoacidosis. There is no insulin produced since it's type 1, guys. We have none. The body killed its own pancreas. And as usual, no insulin means no sugar in the cell. Therefore, the body must burn fat for fuel, resulting in fat waste, and ketone bodies are produced. Kind of like how a diesel engine blows off a lot of exhaust, ketone bodies are very acidic wastes. So we have high acid in DKA, or diabetic ketoacidosis. Now type 2, we have few insulins barely working. So HHNS, or just HHS, let the name help you. So hyperglycemic, we have the higher sugar. Hyperosmolar, we have very thick dehydrated blood. Guys, huge dehydration here. And non-ketonic, we have no ketones, and S is for syndrome. Now, since the body has barely enough insulin to put sugar into the cell, while the body burns sugar for fuel, so we don't get those ketone bodies. So guys, think type 2, you have a few insulins working, so no fat burn, no ketones, since the body's burning glucose. Now, typically, DKA has a faster onset, and consequently, it's easier to fix, since the patients are young with type 1 diabetes. And HHNS is a slower onset with older patients. So guys, it's harder to fix HHNS. Now for the causes, DKA, remember the 3 S's like high sugar. So sepsis, like infection, guys, always an NCLEX favorite. The #1 cause of DKA is infection. Second S is for stress like surgeries or even skipping insulin. Guys, kids in type 1 will get the flu or an infection and then boom, end up in DKA. Or they'll go to surgery without increasing their insulin dose and then bam, DKA. And similarly, on the other side, older patients in HHNS commonly caused by illness and infections. So what are the main differences in the signs and symptoms? Well, for DKA, this is super hard, right? Just remember the acronym DKA. So D for a dried body, guys, and high sugar, 250 to 500 from the lack of insulin. Guys, that's a huge key word, 250 to 500 with type 1 diabetics. Now K is for ketones and Kussmaul respirations, or known as fruity breath. Key words here for the NCLEX, deep, rapid breathing that smells fruity. This is called Kussmaul respirations, so think ketone respirations. So we say, ketones, do you love me? Are you riding? The body is in metabolic acidosis, so the body tries to correct itself, or basically compensate, and get rid of all this acid. It does it by panting like a dog to breathe out all that carbon dioxide, which we call carbon diacid. So remember, we'll see Kussmaul respirations as deep, rapid breathing as the body tries to get rid of all this acid. And the memory trick here is carbon diacid. Now next, our A is for abdominal pain, which is a huge NCLEX tip. HHNS does not have abdominal pain, only DKA, typically on the NCLEX. And our last A is for acidosis, metabolic acidosis, guys. Huge NCLEX key number here. Write this down. pH 7.35 or less. Huge number on the NCLEX. It will always show up on SATA questions. Now switching over to type 2, the slower and more serious one since it's harder to fix. So HHNS, guys, remember the triple H's here. We have higher sugar loss with higher fluid loss, so sugar over 600 plus and extreme dehydration. And our third H is for head change. Now the NCLEX term is neurological manifestations. Guys, write that down. We'll often see confusion with classic signs of HHNS. Guys, we don't get head change or neurological manifestations with DKA. Our next N is for no abdominal pain, guys. DKA, we have that abdominal pain, as well as no ketones. So this means no acid, no Kussmaul respirations, basically meaning no fruity breath and no deep, rapid breathing. Now that's probably the biggest difference than DKA. And lastly, S is for our slower onset with stable potassium, 3.5 to 5.0. So when you get an NCLEX question stating high sugars with neurological changes or neurostatus changes, guys, with no acid, definitely HHNS. And if you get a question about a diabetic kid with abdominal pain and that pH less than 7.35, guys, it's most definitely DKA. So guys, what are we gonna do about it? So for DKA treatments, simply remember the acronym DKA. D for dehydration. Guys, we treat the dry first. Keyword is 0.9% normal saline. Now, I got a lot of questions on this from our NCLEX review, so please write this down. Your first priority action for both DKA and HHS is fluids. And the correct answer is always normal saline. Now, K is to kill the sugar slowly, guys, to prevent that low sugar. So we do keyword here, hourly blood sugar checks. Write that down. We want a slow sugar drop. Sugar is really way high, kind of like a plane. So guys, we want to land that plane slowly, not too fast, since we don't want to crash our patients here. The main goal here is to prevent that low blood sugar, that hypoglycemia, that 70 or less. So a slow sugar landing is the goal. So basically, as sugar lowers, then the insulin lowers. We just titrate or adjust the insulin drip and lower them together. Typically, any sugar over 250, we give IV insulin. Now, key term here, regular insulin only. So remember, regular insulin is ready to go IV. And we start with the bolus first, basically meaning rapid infusion. Now, caution, tests will try and trick you guys. Only regular insulin is put right in the vein. Not NPH, not Aspart, not Lispro. No one else here gets the VIP pass. Remember, only regular insulin is right in the vein or ready to go IV. Now, when sugars drop below 200 or when, keyword, write this down, ketones resolve. This means the body is now burning glucose for fuel and not fat anymore. So we switch the patient from IV insulin to sub-Q and then add some dextrose sugar to the IV bag, typically D5W. Now you're probably asking, why do we add sugar if the sugar is already high? Well guys, it's kind of like landing that plane. Sugar is our landing gear. We want a smooth and slow landing, preventing that low sugar crash of hypoglycemia. Now, a common test question is always a question about a child in DKA who's too nauseous to eat or maybe vomiting. And the question always says, do you still give him insulin if he doesn't have food? So think about it here, guys. Well, yeah, you still give the kid insulin, guys. His sugar's really, really high. Big NCLEX tip, still give insulin on those sick days. Lastly, we add the potassium. Key word here, write this down. During IV insulin, not after, during, big NCLEX tip. And yes, even when potassium is normal between 3.5 and 5.0. Now you're probably asking yourself why. Well guys, remember, insulin puts sugar and potassium into the cell. So naturally both sugar and potassium drop together. So to prevent a potassium crash, we add potassium, sort of like how we add sugar. Now, a little side note about potassium. Think potassium pumps the heart. So the 4 rules of potassium revolve around protecting the heart with potassium. Number 1, our first action is heart monitor placement. And secondly, guys, we never push potassium. This means sudden death. The heart will cramp up and not pump anymore. Third, we only do 10 to 20 mLs max per hour. Not 30 minutes, not even 45 minutes, guys, per hour, a full 60 minutes or more, usually around 4 hours. And lastly, we always put potassium on an IV pump. Never a solo drip, guys, it's too risky. And as always, slow the infusion pump if the arm starts burning, which is pretty common. Now to help you remember the ECG rhythms with high versus low potassium, our memory trick is very simple here. So just think high potassium, we have high pumps. So we get peak T waves and ST elevations for potassium over 5.0. And the exact opposite for low potassium below 3.5, just think low pumps. So we get flat T waves and ST depression, and even this weird little U wave. What the heck's a U wave? Shut up, you. Now for HHS treatments, guys, remember the acronym HS. We always treat the hydration first. Both DKA and HHS, hydration first. 0.9% normal saline. Huge NCLEX tip, guys. Now, we can always do hypotonic fluids, but that's not as common on the NCLEX. And then S for stabilize the sugar with insulin. Again, caution guys, only regular insulin is ready to go IV. Big NCLEX tip right there again. And just like DKA, we correct the sugars slowly with key term hourly blood sugar checks and insulin going from IV bolus to subcutaneous injections. We land that sugar slow. Now, as far as potassium for HHS, out of 10,000 questions we took while making the script, the potassium only came with DKA. So guys, remember, adding potassium for DKA. But a lot of questions came up about reassessing the hydration status. So write this down, guys. So we reassess both blood sugar and rehydration status. So for hydration, we'll see stable blood pressure, cap refill 3 seconds or less, and guys, skin, write this down, should not be pale or cold. It should be warm and have some color. Urine output should be 30 mLs per hour or more with normal specific gravity. Too high and the body is dry. So the little memory trick here is hemoconcentration is an indication of dehydration, basically meaning high and dry lab values, very heavy urine. And hemodilution is overhydration, low liquidy labs with low liquidy urine. Lastly, don't let the NCLEX trick you. Rehydration status does not include apical pulse, lung sounds, or even pupil assessment. All right, guys, that wraps it up. DKA versus HHS. Thanks so much for watching. For our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing to our YouTube channel. Last but not least, a big thanks to our team of experts helping us make these great videos. All right, guys, see you next time.
So thanks for your listening. I hope again it was interesting summary for all of you. So I think by this I am done with my topic DKA. So please, if you have any question for diabetes DKA, please, it's the time now to discuss together. Please write down in the chat box or type down in the Q&A box your point that should be clarified for DKA. So I will give you a few minutes for discussion. Please, I'm waiting your questions. Please, again, if you have any question, raise your hand or type down in the chat box or Q&A box. Maybe there is one question, but I'm not sure about this question. It is written here, hypoglycemia and anesthesia. Usually before any surgery, you have to check if the patient blood glucose is okay in any diabetic patient. Make sure no hyperglycemia emergency. DKA or HHS giving either intraoperative insulin infusion with fluid in the other hand, or in the other side, maybe you can give GIK solution, glucose, insulin, potassium, to control blood glucose in the OR. This is another situation, you have two choices to control during the operation. This is what we are usually, it's called pre-operative or perioperative correction of blood glucose, pre-operative preparation. This is what we are usually giving the patient MBO, giving the proper management, as we mentioned, two choices to manage the case of hyperglycemia. I have one question again here. If an iron gap is down, electrolyte is corrected, but blood glucose is still high, do we discharge the patient? So again, if the patient with resolved DKA, pH should be corrected, blood glucose should be down, an iron gap should be down, patient is clinically, this is very important, able to eat and drink. If all of these are okay, yes, this is a resolved DKA. You can stop the infusion, give basal insulin with boluses pre each meal. So the question here, if all criteria are okay, clinically patient is okay, and there is mild hyperglycemia, yes, you can give insulin injection subcutaneously and discharge patient from ICU to the ward and monitor and titrate your insulin. Definitely, if the patient start eat and has, again, hyperglycemia at home, it means patient is not controlled. But again, very important issue, if the patient with mild DKA, you can use subcutaneous insulin. So in this situation, all criteria are fulfilled except blood glucose is mildly elevated, maybe you can, yes, give the insulin injection and titrate it and monitor your patient. I hope that I answered your question. If no further questions, I conclude here. It's the time now to go for a break. I think the next topic will be about 7 p.m. to be started with one of my colleagues. Thanks for listening. Hope to see you soon in another event. Assalamu alaikum wa rahmatullah.
This good organization of this course. I will talk about diabetes internal feeding. As we know, diabetes is a common disease. A lot of patients nowadays are diabetic. Some of our patients, they are bedridden, or they depend on the internal feeding. Internal feeding means the food enter the gastrointestinal tract with other entry sites rather than the usual tract. Usual internal feeding is the method of getting fluid and liquid food into the digestive tract. People who are unable to eat and swallow safely the fluid and feeds is introduced through the tube, which may be inserted through the nose, nasogastric tube, like this tube, directly to the stomach, or jejunostomy tube to direct to the jejunum, or gastrostomy tube to the gastric, or jejunostomy tube direct to the intestine. So there is two methods of internal feeding: through the nasogastric tube direct to the stomach, who for people cannot swallow, or patient bedridden, or they have coma or unconscious. Some patient like bedridden patient, they insert tube direct to the stomach called gastrostomy tube, or the tube inserted directly to the intestine to the jejunum called jejunostomy tube. So the feeds contain vital vitamins, nutrients, including carbohydrates, sugar. Carbohydrates are needed by the body for energy. The cause of glucose level and blood to rise. So this food is rising the blood sugar. And in people with diabetes, the blood glucose may rise to high level with this, and treatment is needed. Aim of the feed and diabetic treatment to provide adequate nutrition and avoid high or low blood sugar. So diabetes, as we know, is a chronic disease and for a lot of patients, and ended or complicated by micro or macrovascular complication if uncontrolled. It's a common disease and for all the world, and expected to rise in the next following years. It's there is 50% increment of the prevalence of diabetes in the following years from 2019 to 2045. And Middle East also, it's double prevalence increase expected to happen if no action taken for this high risk area in our area, Middle East, around 96% increment in the prevalence of diabetes in the coming years. So the prevalence of diabetes in 2000 year is 1,151 million global prevalence of diabetes in the youngest age, and expected to rise double the number in 2090. So the diabetes is a long-term chronic disease characterized by hyperglycemia. There is 3 common types of diabetes: type 1 diabetes with insulin-dependent diabetes. It's involved 10% of the people, and 90% of the diabetic patients are type 2 diabetes. They are using oral hypoglycemics. Some of these patients, they have used insulin. And one form of diabetes involves pregnancy called gestational diabetes, which disappear after pregnancy in 50% of the gestational diabetic patients. And some form of diabetes called pre-diabetic, and this is the stage before the diagnosis of diabetes. And I will talk about the pre-diabetes diagnosis in the following lecture, inshallah. The type 1 and type 2 diabetes is common symptom of polyuria and decreased weight and catabolic state, especially in type 1 diabetes. And in type 2 diabetes, they have neuropathy. They start to have neuropathy and also a vision problem, and some of male patients complaining of erectile dysfunction, and some of female patients complaining of vaginal infection due to diabetes and hyperglycemia. So the common symptom is polyuria, polydipsia, weight loss, and blurred vision, and the recurrent urinary and vaginal skin infection. So the prevalence of diabetes in Saudi Arabia, Dr. Rabi'an and his group, they discovered the prevalence of diabetes in 2014 around 25% diabetes. This is the common study in Saudi Arabia. Dr. Nuzha in 2014, the prevalence of diabetes is 23, and Al-Qurashi in Dr. Al-Qurashi in 2011 around 31% prevalence of diabetes, and Dr. Rabi'an in 2014 he discovered around 27% prevalence of diabetes in male and 21 in female. So the normal, what happened to our body? Usually glucose is our foods contain glucose, especially carbohydrate, and this is the insulin. The glucose usually enter the cell by help of the insulin. So insulin is the like soldier, is allowing glucose to enter safely to the cell to be utilized as energy source. As I said before, there is a lot of common type of diabetes, type 2 diabetes, type 1 and gestation diabetes, and some of diabetes are run in family called medullary onset diabetes, and some rare disease like late onset autoimmune diabetes, which is type 1 in old patients. And type 2 diabetes, as we know, this the soldier is insulin, and this is the glucose. There is a lot of glucose accumulating in the bloodstream because the insulin cannot help the glucose to enter the cell because there is a low level of insulin or insulin insufficiency, or there is insulin resistance. So a lot of glucose accumulating in the blood stream and cause hyperglycemia, would ended by polyuria, polydipsia, and a few glucose particles enter the cell to utilize for energy. Type 1 diabetes is caused by destruction of the beta cells, so no insulin, so the patient is dependent on insulin. Type 1 diabetes, there is no insulin, so a lot of glucose accumulating in the bloodstream, while in type 2, there is insulin, but not enough insulin, and there is insulin resistance, so ended by accumulation of the glucose and hyperglycemia. So American Diabetic Association diagnosis of diabetes depend on the following criteria: fasting blood sugar equal or more 126 milligram, fasting 8 hours, random blood glucose 200 or more with symptom, after GTT 2 hours 200 milligram blood glucose or more is diagnosed of diabetes, and hemoglobin A1C 6.5 or more are diagnosed of diabetes. And this is the pre-diabetic. Pre-diabetics, the hemoglobin A1C from 5.7 to 6.4, fasting blood glucose from 100 to 125 is in the range of pre-diabetes, and 2 hour post GTT 140 to 199 is in the rate of pre-diabetes. So internal feeding, for reminder, there is the entering of the food and fluid through the to the alimentary tract by using the tubes like nasogastric tube directly to the stomach, or gastrostomy tube to the stomach, or gastrostomy tube to the jejunum if there is disease in the stomach or tumor. So the feeding, the right insulin for the feeding, it contain the feed should agree the following assessment by the dietitian. It include adequate vitamin, minerals, fat, protein, carbohydrate, and fluid, as well as right number of calories to maintain the ideal body weight. However, in people with diabetes, the carbohydrate content of the feed make the blood sugar rise up, and the kidney respond to this, taking glucose from the blood and moving it to the urine, so there is polyuria and polydipsia. So the feeding, most of diabetic patients are not available liquid form of the exception of metformin. So the diabetic medication is not available in liquid form except metformin. Tablets should not be used, crushed and inserted to the tube, because it may cause the blockage of the feeding tube. So the tablet is not advisable for this patient using internal feeding. Therefore, the other diabetic medication is required to control blood glucose. Insulin therapy is needed. So insulin is the mandatory for these bedridden patients using internal feeding and suitable for them, and avoiding of the tablet medication because it's internal tubes. There are a number of different types of insulin, which is vary in how and quickly and how long of the last duration of the insulin. The type of insulin used depend on the content and duration, frequency, and rest of period, current hemoglobin A1C level, age, body weight, and of the individual, and frequency of the feed. Depend on the dose of insulin. The insulin need to work during the time that feed active when glucose level and the blood sugar rising. If there is a mismatch, blood glucose may drop to low level, so it's called hypoglycemia, or rise high level to cause hyperglycemia. So the blood glucose target pre-feed should be between 5 to 8 millimole from 90 to 144. This is the target blood sugar between the meal, pre-meal, and post-prandial should not rise more than 216 milligram per deciliter. However, target need to be individualized. So the blood sugar not rise after meal more than 200 to 200 around 220 milligram per deciliter. It's depends on the feeding of the patient. Prolonged feeding. Some patients use prolonged feeding, overnight feeding. Intermediate insulin is given as a basal insulin at the start of the feeds, and mixture of intermediate and short-acting insulin is given at the start and halfway through out the feed. Bolus feeding, if the patient use prolonged feeding, we can use a mixed start containing mix insulin or premix insulin from the start of the feeding. It's contain short acting and intermediate acting. It is suitable for this type of feeding. So premix insulin is suitable for this type of prolonged feeding because it contains intermediate action insulin and short-acting insulin, and it's enough for control of the hyperglycemia. For patient using bolus feeding, short-acting insulin at the beginning of every feed, and insulin is also needed in people with type 1 diabetes. So in patient using bolus feeding, we are using a short-acting insulin at the beginning of every feed. And also we can use also basal insulin to cover the basal requirement of insulin. And this is especially in type 1 diabetic patient. So in bolus insulin, bolus feeding, we can use bolus insulin, short-acting insulin with a basal insulin. Patient with continuous feeding, intermediate or long-acting insulin is given in the beginning of the feeding. Short-acting insulin is given with the each meal or supplementary feed consumed. This to simplify the issue. If the patient use overnight feeding, we can use a mixed premixed insulin. If the patient use twice feeding, we can use a premixed insulin. It's contain short-acting with intermediate acting insulin. Patient use bolus feeding or continuous feeding, we can use a basal insulin, which cover the basal requirement of the glucose for insulin. And we can use short-acting insulin as a corrective dose, or we can use it each feeding. If there is patient goes for high blood sugar, we can use a corrective doses of short-acting insulin depending on the glucose. Blood glucose level will rise too high, so we can use the short-acting insulin to correct hyperglycemia as needed. So if the dose is not controlled, we can adjust the dose according to the target blood sugar. Target blood sugar more than less than 220 after meal, and pre-meal should not rise more than 140. However, other factors can cause high blood sugar level need to be identified. If the patient rising the blood sugar while using same food, think about the other causes of hyperglycemia like infection, pain, stress, steroid treatment, weight gain. This make the body less sensitive to the active action of insulin, changing the feed to one with more carbohydrate without increase in the insulin dose, incorrect omission of the insulin, and poor injection sites, lipodystrophy, which prevent insulin absorption, equipment failure or misuse. So this is if the patient has hyperglycemia while using the same dose of insulin. Think about the other causes of hyperglycemia like infection, pain, stress, using of the medication, insulin injection technique problem, weight gain, it can cause hyperglycemia. So incorrect admission of the insulin. Think about these causes and correct it accordingly. Sign of symptom of high blood sugar, blood glucose testing. This is the most common method used to identify hyperglycemia. Increased urination, patient become dry, dehydration, sleepiness, genital itching and thrush, weight loss, and oral hygiene is essential for people having internal feeding. This is particularly important if blood glucose level is high. Low blood sugar, what's the sign of the low blood sugar? If you measure the blood sugar and become low, this is the most common. And the patient conscious level usually decrease if they have hypoglycemia. So keep the blood glucose level steady and never too low and too high. With diabetes using insulin, the blood glucose may drop too low because maybe a mismatch with the feeding between the insulin doses or type. The carbohydrate content of the feed should be individualized, and we should look for the right carbohydrate. So think about the hypoglycemia, check it. If there is hypoglycemia, adjust the insulin or adjust the feeding. Other factor can increase the risk of hypoglycemia with insulin therapy, like physiotherapy. Patients undergo for the physiotherapy. This is may cause hypoglycemia, restlessness due to pain. Feeding tube is blocked. If the feeding tube is blocked, check it. Maybe it's caused the cause of the hypoglycemia. If the carbohydrate content of the feed is reduced, this can cause hypoglycemia. Feed is interrupted or stopped. Insulin is injected into the muscle, may cause hypoglycemia. Instead of fat, this results in the insulin working too quickly, inserted to the muscle. Adjustment of the other medication, such reduction of the steroid dose, can cause hypoglycemia. Malabsorption, insulin is not given in the correct time, so nearest insulin injection can cause hypoglycemia. So if a patient hypoglycemic, think about the other causes of hypoglycemia, like mismatch feed, blockage of the tube, insulin injected to the muscle, wrong dosing of insulin. Patient get symptom of vomiting, malabsorption, or patient had decreased carbohydrate content of the feed. So sign of symptom of low blood sugar, shaking. Patient is shaking, sweating, pallor, confusion, decreased level of consciousness. Patient has high heart beats, palpitation. How to treat hypoglycemia? If unconscious, lie the person on the side, maintain airway is opened, give glucagon injection. If you don't have glucagon, you can use glucose gel or honey under the tongue or the inside the cheek to easily or sublingual to give a simple carbohydrate and quick carbohydrate for absorption and correction of the blood sugar. If the patient avoid to give any fluid to the mouth for through the mouth for this unconscious patients, and call the emergency to help you to correct the hypoglycemia, and avoid any fluid their mouth. If conscious patient if unconscious and feeding tube is placed, stop the feed, give 15 to 20 gram quick acting carbohydrates like 60 ml glucose juice or 110 to 150 ensure plus juice or 3 tablet teaspoons sugar dissolved in water, warm water, to correct hypoglycemia in conscious patient, or 2 tube of glucose gel, not for fine bone tube, as may cause blockage. Flush the tube with 30 ml of water, wait for 15 minutes and recheck the blood sugar. If still, give another less than 4 millimole per liter. Repeat the treatment with the same action. Once the blood glucose level is above 4 millimole or above 75, resume feeding. If hypoglycemia occur between feeds, treat the above, and once blood glucose is above 4 millimole, connect the feeds and give enough to deliver to 20 gram of carbohydrate. Consider weight, what cause of the low blood sugar, and take the action to avoid recurrence of hypoglycemia. How to often test the blood glucose level? Blood glucose monitoring frequency depend on type of diabetes, treatment, particularly treatment is carrier risk of hypoglycemia, frequency of feeding, number of rest period, stability of the blood glucose and general condition of the patient, level of activity. So general guidance of the monitoring would suggest 4 to 6 hourly blood glucose monitoring is adequate. However, if feeds is interrupted, the frequency and monitoring should be increased to every hour until the feeds is recommended or the action is taken to avoid hypoglycemia. Example, intravenous fluid connected, and appropriate blood glucose targets should be agreed. For most people, this 6 to 12 millimole per liter is given safely and marginal above hypoglycemia, but does not tolerate persistently high level that can cause symptoms. Ketone should be tested in people with type 1 diabetes if the blood glucose level rise more than 15 millimole to avoid any occurrence of diabetic ketoacidosis. If higher more than 2 more occasions, the person is unwell, showing sign of infection. Ketones develop when the body is so severely deficient in the insulin, and glucose cannot be converted to the energy. So the decision made the patient has diabetic ketoacidosis, we should seek medical advice and transfer patient to the emergency room to treat diabetic ketoacidosis. So the key message of the internal feeding: keep safe, regular blood glucose monitoring, know how to identify and treat hypoglycemia, avoid prolonged episode of high blood sugar level. This will result in loss of caloric and nutrient required. People receiving internal feeding missed out on the many benefits of the blood of food and pleasure of eating. Food is an important part of diabetes management, and loss of control over this part of these diabetes can be stressful for these type of patients. I thank you, and also I will go for the second lecture. طيب بسم الله الرحمن الرحيم. For the pre-diabetic patients, usually this is the stage of the diabetes before the onset of diabetes. We should prevent diabetes in patients with pre-diabetic. So the prevention of diabetes type 2, as we know, is important for these type of patients, high risk to develop diabetes in the next few years. Type 2 diabetes mellitus is characterized by hyperglycemia, insulin resistant, and impaired in the insulin secretion. Also, the life risk of type 2 diabetes is high. Our ability to predict and prevent of type 2 diabetes is in general population is a challenge issue. However, individual at high risk, including these patients with impaired fasting blood glucose and impaired glucose tolerance, obese patients, they have risk to develop diabetes. Close relative family history of diabetes, this is risk for diabetes. Patient with certain ethnic group like Asian, Hispanic, African American, they are at risk for develop diabetes. Moreover, genetic risk factor for type 2 diabetes have increasing been identified, and polygenic risk for score may enhance the traditional demographic and clinical risk factor certification in future. So the category increase in high risk to develop diabetes, pre-diabetes, patient with fasting blood sugar from 100 to 125. This is called pre-diabetic. Patient with 2 hours post GTT 75 from 140 to 199. Patient with hemoglobin A1C less than 6.4%. This is pre-diabetic. So pre-diabetes, they in form of the fasting blood sugar 8 hours from 100 to 125. Patient with 2 hours post GTT from 40 to 199, and patient with hemoglobin A1C from 5.7 to 6.4. This is at risk to develop diabetes and called pre-diabetic according to American Diabetic Association guidelines. So goal for diabetic prevention, to prevent and delaying the onset of diabetes, preserving the beta cell, preserving or delaying the macrovascular complication, reducing the cost of diabetes care. Criteria to testing diabetic patient for pre-diabetic. patient with first degree relative diabetes. This يعني which patient we should, which community we screen them. Patient with history, patient with first degree relative diabetic, we should screen them, especially patient with overweight, body mass index more than 25%, patient high risk in high ethnic group like African American, Latino, and also Asian American, and also our area, history of chronic vascular disease, patient with hypertension, usually at risk to develop diabetes, patient with hypercholesterolemia, patient with history of polycystic ovary syndrome, this is at risk to develop diabetes, patient with physical inactivity, other condition associated with the insulin resistant like severe obesity, acanthosis nigricans, patient with pre-diabetic, as we know, the hemoglobin A1C from 5.0 or more, or after oral GTT, blood sugar from 140 to 199, or a patient with fasting blood sugar from 100 to 125. Patient with the pre-diabetic, as we know, patient with history of gestational diabetes should have lifelong testing every 3 years. For all the other patient, testing should begin at the age of 35. If results are normal, testing should be repeated at minimum 3 years interval. Patient with HIV also should be screened for diabetes. American Diabetic Association criteria for diagnosis for diabetes, as we know, hemoglobin A1C 6.5 or more, fasting blood sugar 126 or more, 2 hour post GTT more than 200, or random blood sugar more than 200 with symptom. So we should identify patient pre-diabetic or at risk, as we know, family history of diabetes, high risk patient, and racial high risk patient with hypertension, dyslipidemia, patient with history of cardiovascular disease, patient with polycystic ovary disease, patient taking medication like steroid, overweight patient also. 75 gram GTT often used to diagnose pre-diabetic. After 2 hours, blood sugar from 140 to 199. This is the risk for diagnostic for pre-diabetic. So lifestyle modification, all patients with impaired glucose tolerance test and impaired fasting glucose, or patient that pre-diabetic should go for lifestyle modification, behavioral support, dietary therapy, physical activity, smoking cessation. This is the form, this is the action taken for preventing of diabetes. The goal for lifestyle intervention and weight loss, return to the normal glycemia, and regular reinforcement of the program is important for successful compliance. So assess respond to lifestyle intervention for patients with abnormal glucose metabolism and pre-diabetic stage, participating in the lifestyle modification program, reassess fasting glucose and hemoglobin A1C annually. So if the patient go for lifestyle modification program, assess the hemoglobin A1C and fasting blood sugar annually. Management of lifestyle intervention, if unsuccessful, for selected patient age less than 60, body mass index more than 435, and a patient with history of gestational diabetes. This is a patient indicated to medical therapy using a metformin if no contraindication. So metformin is indicated for this type of patient, pre-diabetic, age less than 60, history of gestation and diabetes, or patient body mass index more than 35. This is indicated for metformin therapy as diabetic prevention program suggested. So this is the indication for metformin therapy. So in the older patient, more than 60 years of age, lifestyle intervention was particularly effective. No need for medication for patient more than 60. Patient treated with metformin required at least annual monitoring of hemoglobin A1C and fasting blood sugar. Patients are not treated with metformin should also be followed with the repeated examination, annual measurement of the fasting blood sugar, hemoglobin A1C, as well as the serum lipid. If fasting blood sugar increase more than 26, they are diabetic. And also if the hemoglobin A1C more than 6.5, they are diabetic. And appropriate management should be taken in consideration. Measurement of the management of lifestyle intervention. If successful, patients who improve and maintain their glycemic indicate the lifestyle intervention should be continued. Diet and exercise with repeat examination and measurement of fasting blood sugar, glucose, and hemoglobin A1C, serum lipid on annual basis. So if the lifestyle modification success, we continue with it in this lifestyle modification program, and we should assess the hemoglobin A1C and the fasting blood sugar and lipid every year. If not successful, we'll repeat this investigation and patient go for diabetes. We'll treat the diabetes type 2 accordingly. So the main milestone for the treatment of pre-diabetic is lifestyle modification. We promote lifestyle changing, healthy diet, regular exercise to all patients. Efficacy of lifestyle intervention. It's dependent on the compliance of the diet and exercise of the patient. If the weight loss happened and increasing activity can improve the glucose and tolerance and prevent progression of the type 2 to type 2 diabetes. There is most common study in this issue to study the effect of the lifestyle modification in pre-diabetic called diabetes prevention program. This is involve a lot of patients, a lot of country undergo for from different country and undergo for this study, and they discovered the intensive lifestyle changes aim to reduce weight by 7%, and modification program aim to low-fat diet and exercise for 150 minutes per week, around 30 minutes every day. Treatment used in this study was metformin 850 milligram twice daily, plus information on diet and exercise. So they discovered the lifestyle intervention more effective than metformin therapy. Metformin and lifestyle intervention were similarly effective in reducing the incidence of diabetes in women and with the history of gestation and diabetes. Persistent benefit after the intervention, follow-up of 15 years showed the continued benefit of original lifestyle intervention and metformin group with long-term reduction in diabetes development from 27 to 18% respectively, compared with the original placebo group 50 to 56 to 52. So there is continuous benefit for right lifestyle modification and metformin use to prevent diabetes in this pre-diabetic group. So both lifestyle intervention and metformin therapy are effective to prevent diabetes. A cost-effective analysis using data from diabetes prevention program, 3 years showed that lifestyle intervention was cost-effective compared to the placebo. Moreover, metformin was acutely cost-saving. Exercise also is no one exercise prescribed for all individuals. Adult high-risk patients, they are encouraged to have 30 to 60 minutes moderate intensity aerobic activity on most days of per week, at least 150 minutes per week. The benefit of exercise in preventing diabetes has been demonstrated in several studies. And meta-analysis of 28 prospective cohort study, physical activity and type 2 diabetes reported lower risk for developing diabetes with 150 minutes per week, moderate activity, moderate physical activity. Additional benefits were seen if the higher level of activity, more than 300 minutes per week, to decrease relative risk. So diet, choosing the dietary pattern of helpful food, such as dietary approach for stop hypertension, DASH diet or Mediterranean style diet, rather than focusing on specific nutrient. This approach allows greater flexibility and personal preference in diet and may improve long-term adherence to these diets, healthy diet. So this is the trials involving and studying pre-diabetic prevention in diabetic patients. The most common study is diabetic prevention program. It discovered the lifestyle modification in prevention of diabetes very effective. It's prevent around 56 versus 0.1 in control, and lifestyle modification versus control also. This is to decrease weight and prevent the diabetes. This decrease weight around 5.6 in the study group, and decrease while placebo 0.1 to decrease weight, and only the prevalence of diabetes in the study group using diabetes prevention program was 14 versus 29% in the placebo group. So it's very effective and evidence of the decreased diabetes prevalence. So also smoking cessation, several large study showed that cigarette smoking increased the risk of type 2 diabetes. Effect of the smoking cessation on diabetes risk is variable and may depend on the individual's patient factor. Smoking cessation may reduce the diabetes risk by reducing systemic inflammation. Pharmacological therapy, as I said before, is indicated in some patients to prevent type 2 diabetic patients if lifestyle and modification is not effective, or beside the lifestyle modification, especially in patients in category the age less than 60, body mass index more than 35, or patient with history of gestational diabetes. Lifestyle changes have not been shown to reduce morbidity and mortality. Thus, the lifestyle changes are generally beneficial and don't have any adverse effects. Choosing drug therapy, as I said, patient in youngest age less than 60, body mass index more than 35, or patient with gestational diabetes, history of gestational diabetes. The metformin is indicated for these type of patients. The dose usually 850 milligram once daily for 1 month, and can increase to as tolerating to 850 milligram twice daily. Metformin has been approved for prevention of several studies for prevention of diabetes, but remain off-label for prevention in United States. For individuals with impaired, for pre-diabetic who are candidate for obesity pharmacy, semaglutide pharmaceutical pharmacy, some study suggests semaglutide Ozempic to use a treatment of obesity may help to reduce risk for progression of type 2 diabetes. So rather than metformin and trials shows decrease the new onset of diabetes compared to diet and exercise. And the largest trial, the meta-analysis, the diabetes prevention program, metformin reduced rate of progression to diabetes compared to the placebo. Semaglutide in individual with pre-diabetic, overweight, obesity, semaglutide may help to delay and prevent diabetes onset when used as obesity pharmacological therapy. And pre-specified secondary analysis from the semaglutide treatment effect in people with the obesity step 1 trial, adult with pre-diabetic, mean body mass index around 39%, hemoglobin A1C approximately 5.9. It showed the once weekly semaglutide 2.4 milligram for 68 weeks had lowered the frequency progression of type 2 diabetes rather than those with the received placebo 0.5 versus 3%. So does not recommended drug for treatment of pre-diabetic: insulin, liraglutide, pioglitazone, risdiplam, orlistat, alpha-glucosidase, vitamin D, and sodium SGLT2 inhibitor, and nitroglenides is not recommended for treatment of pre-diabetic. So the guidelines, it's recommended as according to American Diabetic Association in patients and pre-diabetic and hemoglobin A1C 5.7 or fasting blood sugar from 100 to 120. Specific group, this weight reduction it should be recommended. Lifestyle modification, moderate onset exercise, smoking cessation is recommended for these type of patients. American Diabetic Association recommend use a medication like metformin in patients with age less than 60, body mass index more than 25, or patient with women with history of gestation and diabetes. Usually we use a metformin in dose of 850 milligram once daily for 1 month, and the dose can increase twice daily after 1 month as tolerated. And hemoglobin A1C, fasting blood sugar should be monitored annually. Community Prevention Service Task Force recommend combination of diet and physical activity program for individuals increased risk for diabetes. Nice guidelines in the United Kingdom. The guidelines recommend to use also lifestyle intervention for these type of patients. So summary and recommendation goes for treatment of why we are concerning to prevention of diabetes, to prevent any development of onset of diabetes and prevent the micro and macrovascular complication, especially in high risk group, in the obese patient and patient with family history of diabetes or in ethnic group. Lifestyle intervention is mainstone treatment for these type of patients. And these type of patients maybe need metformin if the therapy, if the body mass index more than 35 or the age less than 60, or they have women, they have history of gestation and diabetes. And monitoring of the hemoglobin A1C and fasting blood sugar should be done annually. So this is the indication of the patient with if they are pre-diabetic. We should this is the treatment of recommended if the patient population, if the pre-diabetic individual less than 60 body mass index more than 35, history of gestation diabetes, metformin is indicated. In this type of patient of only if they not in category of the metformin, the lifestyle modification and exercise is recommended for these type of patients. I want to thank you, and if you have any question, you are welcome. Okay, if you don't have any question, I'll go. Sure.
بس ثواني نعمل شير مثل السكرين ادفانس. ما أدري بس إذا في أحد يساعدني كيف أعمل شير مثل ثواني. ثواني بس. واضحة الآن؟ أوكي تمام. بسم الله الرحمن الرحيم. I am Dr. مشاعر الحربي, consultant family medicine diabetes management. Today we talk about diabetes mellitus overview, and we talk about other type of the diabetes like gestational diabetes or moody. What are the major type of the diabetes? First, we start by defining diabetes. Diabetes is a chronic disease characterized by hyperglycemia secondary to dysregulated carbohydrate metabolism, resulting from insulin deficiency, insulin resistance, or both, which, if left untreated, may lead to the mortality and morbidity. The main type of the diabetes, type 1 diabetes, type 2, a specific type of the diabetes like gestational diabetes or monogenic diabetes syndrome like neonatal diabetes or moody or drug or chemical induced diabetes. Fourth type, which is gestational diabetes mellitus that occur at pregnancy. Why is it important to classify diabetes? ما أدري أنتوا حابين إحنا نتكلم بالعربي بالإنجليزي أو مع بعض الاثنين ميكس اللي أنتوا حابينه. أوكي تمام. طيب إذا كثير من الناس يقولوا طب أنا ليش أفرق بين classifier for diabetes? What is the benefit for the patient, for the doctor? Okay. To personalize the treatment plan based on pathophysiology and the natural history of the disease progression. Classify the type of the diabetes, help to identify family member who may be at risk as well. يعني معنى الكلام هذا إنه كل مريض سكر له خطة علاجية خاصة فيه، قائمة فيه هو لحاله. ما ينفع الخطة حقت أحمد هي نفس الخطة حقت فاطمة، هي نفسها الخطة حقت نوف. لازم كل مريض سكر له خطته هو الخاصة فيه لحاله. عشان كده مهم إني أشخص السكر، هل هو النوع الأول، النوع الثاني، سكر الحمل، السكر نتيجة علاج معين. تمام. اوكي. What are the signs and symptoms of the diabetes؟ ايش هي الاعراض اللي ممكن تجي للمريض السكر النوع الاول؟ بوليوريا، بوليديبسيا، ويت لوس، فتيق. كثير من المرضى يجوا يقولوا دكتورة أنا صرت أحس إني أروح الحمام كثير، أعطش كثير، وزني نازل. كثير بيقولوا لي روح افحص سكر، ليش الثياب عليك واسعة، أو تعب. Children and adolescents are more likely to present with the classic sign and symptom. Adult with type 1 diabetes, variable sign and symptom making diagnosis difficult. التشخيص أسهل في الأطفال وفي الصغار. تمام. غالبا الأطفال لأنهم ملاحظين من الأهل، من الأب والأم، خاصة كمان المراهقين، لكن الكبار لا، شوي حيكون صعب الموضوع. التايب 1 دايبيتس نص البيشنت اللي هم children and adolescent يكونون متشخصين بدي كي اي. لو تيجي تسأل المريض انت كيف تشخص سكر؟ الشخص سكر جاتني حموضة في الدم. طيب ايش معنى كلمة حموضة في الدم؟ دايبيتيك كيتو اسيدوزيس. ايش يكون مع المريض سيمتوم او اعراض؟ المريض يبدا يحس غثيان، استفراغ، يقول لك تعبان، معاه جفاف، حموضة. في بعض الدول خاصة مصر ما يقولوا الحموضة في الدم، يقولون كيتون، يكون معايا كيتون. ميتابوليك اسيدوزيس، اكيوت كدني انجري، هايبوكاليميا. طبعا والسكر يكون فوق 300. اوكي. This is about type 1 diabetes. يعني عندنا التايب 1 diabetes يكون يشتكون يا اما acute condition اللي هي دي كي اي diabetic ketoacidosis، او يجي يشتكي البيشنت من بوليوريا، بوليديبسيا، بوليفاجيا، ويت لوس، فتيق. تمام. طيب او دي كي اي. كده خلصنا من التايب 1. نجي عند التايب 2. نفس الأعراض بوليوريا، بوليديبسيا، فتيق، بلرت فيجن. كثير من البيشنت يجي يشتكوا يقولوا دكتورة صرت ما أعرف أسوق في الليل، صرت أشوف زي النجوم قدامي. بور ووند هيلينج. كمان في إضافة هنا UTI multiple UTI infection تكون as symptom of the type 2 diabetes or dry skin. أحيانا البيشنت asymptomatic على فكرة. And the diagnosis is discovered by healthcare professional on screening. في كثير مرضى يجوا يشتكون بس ثواني. اوكي. فزي ما قلنا التايب 1 هم نفس الاعراض تبع التايب 2، حيكون معاهم بوليوريا، بوليديبسيا، بوليفاجيا، الفتيق. يشتكي المريض كمان يقول دكتور صرت ما اعرف اسوق في الليل، صار في غباش قدام عيوني، دكتورة صرت لما انجرح يطول الجرح على ما يبرى. الفيميل كمان يشتكون من كثرة الالتهابات، خاصة الالتهابات اللي هي التناسلية. في شيء ثاني كمان الجفاف. تمام. وفي أحيانا المريض ما يشتكي من أي عرض، يقول دكتور أنا فجأة كنت ألعب بالجهاز حق الوالدة حصلت السكر 300. فجأة كنت ممرضة جاتني كانت تقول فجأة أنا كنت ألعب كذا بالنايت، كانت نايت شيفت، وقست السكر بالجلوكوميتر، قست السكر حصلته 500، نزلت تحط له معايا السكر. فالأعراض ممكن تكون أكيوت، ممكن تكون أسيمتوماتيك. طيب what is the pathophysiology of the type 1 diabetes؟ عشان نفهم المانجمنت بلان، عشان نفهم البروجنوزس الديزيز، لازم نفهم الباثوفيسيولوجي of the type 1 diabetes. clue to diagnosis type 1 diabetes، لازم يكون عندنا pancreatic autoimmunity، والشيء الثاني يكون عندنا low level of the C-peptide. السي-بيبتايد ايش هي؟ هي المركب اللي يكون قبل افراز الانسولين. اذا كان عندنا المركب اللي قبل افراز الانسولين قليل، يعني معناته كمية الأنسولين ما حتكون موجودة. تمام؟ هذا رقم واحد. رقم اثنين الأوتو اميونيتي اللي هي الأنتي بادي، اللي هي الأجسام المضادة، اللي غالبا نقول للمرضى روح اعمل أجسام مضادة، أو خلينا نطلب لك أجسام مضادة عشان نفرق أنت النوع الأول ولا النوع الثاني. إيش هي الأجسام المضادة؟ في أنواع كثيرة، بس أكثرها اللي هي الآيلت سيل أوتو أنتي بادي تو ذا جاد، جلوتاميك أسيد ديكربوكسيليز، أنسولين أنتي بادي، ترايوزينيز، ترايوزين فوسفاتيز ايلت انتيجين 2، زنك ترانسبورتر 8. Okay. People with type 1 diabetes also or other autoimmune disorder، يعني معناته انه يكون مريض السكر النوع الاول مو بس معاه عنده السكر، عنده كمان غير كذا هاشيموتو ثايرودايتس اللي هي امراض مناعيه اخرى، يا مثلا هاشيموتو ثايرودايتس، جريفز ديزيز، سيلياك ديزيز، اديسون ديزيز، اوتو اميون هيباتايتس، بريشز انيميا. البي ام اي يوجوالي نوت اليفيتد، يعني غالبا النوع الاول ما يكونوا سمين، تمام البيشنت، لكن اساسا احنا عندنا السمنه في زياده. اوكي، فممكن يعني لا تلخبطنا انه خلاص اي سمين معناته تايب 2، لا. البي ام اي ما نعتمد عليها اعتماد كلي، لازم اكثر الكريتيريا او كل الكريتيريا تكون موجوده. تمام. طيب الباثوفيسيولوجي اوف ذا تايب 2 diabetes. اوكي، تايب 2 diabetes يكون عندنا decrease insulin secretion and increase insulin resistance. اوكي، this lead to the type 2 diabetes. decrease insulin secretion. اوكي، ما عندنا انسولين يفرز من البنكرياس، بالمقابل عندنا الانسولين الموجود اللي هو شويه في مقاومه له. تمام، this lead to the type 2 diabetes. اوكي، important factor contributing to the hyperglycemia. ايش هي العوامل اللي ممكن تؤدي للهايبرغليسيميا؟ decrease insulin secretion زي ما قلنا، decrease incretin effect. اوكي تمام. decrease incretin effect اللي هي decrease incretin effect معناته هي الآن الأدوية الموجودة اللي هي الجي ال بي، الجي اي بي، المونجارو، الأوزومبيك، هي تعمل عمل النكريتين افكت. تمام، increase اللايبوليسيس، increase glucose reabsorption، decrease glucose uptake. اوكي، impaired insulin secretion and decrease glucose uptake. هذه هي الباثوفيسيولوجي of the type 2 diabetes. طيب screening for diabetes. معلش في مشكلة في الزوم خرجني. طيب زي ما قلنا هنا معلش هو المين type of the diabetes type 1 diabetes type 2 diabetes a specific type of the diabetes gestational diabetes mellitus. Okay. المودي maternal onset of the diabetes of young is characterized by the early onset of the diabetes in autosomal dominant pattern. يعني احنا تكلمنا عن التايب 1 diabetes، تكلمنا عن التايب 2 diabetes، طبعا حنتكلم عنها بالتفصيل دحين، بس خلينا نخلص اول شيء من المودي. المودي يكون البيشنت يجي يشتكي، يكون عمره قبل 25 سنة، يقول لك المريض أنا معي السكر، الوالد معاها السكر، جدي معاها السكر، تمام؟ يعني 3 جنريشن كلهم يكون معاهم الديابيتس. هذا رقم 2. رقم 3 لما نعمل الانتي بادي يكون معاهم نيجاتيف انتي بادي. رقم 4 غالبا معظم الناس يحسبونهم كانهم تايب 1 فيبدوا لهم انسولين لانهم قبل 25 سنة. طيب بس لو شفتوا الانسولين الدوز اللي يحتاجوها جدا بسيطة، يعني يكون 2 يونت 4 يونت، يمكن اليوم كله ما يعدي 10 يونت، تمام؟ هذا يخلينا نشك انه ما يكون تايب 1 دايابيتس، خلينا نشك انه مودي. The most common reported form اللي هو الجي سي كي اللي هو مودي 2 والمودي 1 والمودي 3. كلينيكالي البيشنت الجي سي كي اساسا يكون معاهم مايد ستيبل فاستنج هايبرجلايسيميا وما يحتاجون ميديكيشن. في البيشنت اللي هم يكون معاهم مودي اذر مودي يكون لو دوز اوف ذا سلفانيوريا. هنا الجدول يميز لي انواع المودي الموجوده على حسب الجين، نسوي لهم اختبار للجينات وعلى حسب الجين. ليش مهم اني افرق بين انواع المودي؟ لانه في بعض المودي يكون ما يحتاج علاج، في بعضها لا يحتاج لو دوز اوف سلفانيوريا، تمام؟ جاتني مريضة الأسبوع اللي فات عشانها متشخصة وهي صغيرة، شخصوها على طول بدوا لها MDI انسولين، مع إنه هي لو شفنا جرعات حقتها اليومية ما تعدت 10. قلت لها خلاص إحنا نبغى نوقف النوفورابيد، تمام؟ بس هذه البيشنت يحتاج لها كلوز فولو اب. نبغى نوقف النوفورابيد اللي هو الانسولين قصير المفعول ونخليك على اللانتوس، لاني خفت انه احتمال تكون في الهاني مون بيرد، تمام؟ اللي هي بعد تشخيص السكر النوع الاول، فمشيناها على اللانتوس. لما جينا وقفنا لها الانسولين اللي هو القصير المفعول ومشيناها على اللانتوس، الى الان سكرها ممتاز. وقفنا لها اللانتوس بالتدريج، امورها جدا ممتازه، ودحين ماشيه على سلفانيوريا. يعني حولناها من 4 injection الى low dose of the dimicron. تمام. Gestational diabetes mellitus may be defined as development of insulin resistance resulting in the hyperglycemia during pregnancy, generally developed under 24th week of the pregnancy. Diabetes in a pregnancy, women who present with diabetes in the first trimester in case of overdiabetes and should not be received diagnosis of the GDM. إيش معنى الكلام هذا؟ معنى الكلام هذا إنه في عندنا سكر الحمل وفي سكر مع الحمل، تفرق عن بعض. سكر الحمل هو اللي أساساً يكون يظهر في 24 أسبوع من الحمل، تمام؟ السكر أثناء الحمل تكون المريضة من أول ما تشخص سكر، بس ما تكون هي عارفة أساساً، أو تكون هي عارفة بتكون النوع الأول أو النوع الثاني. طيب ليه مهم نسأل عن الهايبرغلايسيميا أثناء الحمل؟ لأنها تأثر في تأثير على الطفل وفي تأثير على الأم. There is maternal complication and there is fetal complication. Maternal complication: hypoglycemia, ketoacidosis, pregnancy-induced hypertension, polynephritis, placenta insufficiency, polyhydramnios, pre-eclampsia, eclampsia, preterm labor, CS, and worsening of the chronic complication. Fetal complication: malformation, IUGR, cardiomyopathy, hypoglycemia, hypocalcemia, hyperbilirubinemia and jaundice, hypomagnesemia, microsomia, and intrauterine death. Okay, there is the prevalence of the GDM in the Saudi Arabia is around 20 to 25, which is high. Okay, how to screen for GDM؟ احنا كيف نشخص المريضة اللي عندها سكر حمل او كيف نفحص المريضة عندها سكر حمل؟ هي طريقتين، يا انه في عندنا طريقة الون ستيب اللي هي الخطوة واحدة، او في طريقتين اللي هي القديمة اللي هي تو ستيب. الخطوة الأولى اللي هي بس خطوة واحدة اللي هي 75 جرام oral glucose tolerance test، تمام؟ وفي اللي هي الطريقتين اللي هي بالبداية 50 جرام وبعد كذا نعطيها 100 جرام. الحين نشرحها بطريقة أوضح. اوكي، الون ستيب اللي هي اساسا مستخدمه الحين عندنا في المستشفيات in women not previous diagnosis as diabetes. اي فيميل ما تكون شخصت قبل كذا او اثناء الحمل هذا بسكر، تمام؟ عملنا لها في اول زياره كانت طبيعي ما عندها سكر، نجي على الاسبوع ال 24 ل 28 اسبوع نقول للفيميل تعالي 24 to 28 نعطيها اللي هو 75 جرام oral glucose tolerance test. الoral glucose tolerance test should be performed in the morning after overnight fasting at least 8 hours. لازم الفيميل تكون صايمة 8 ساعات. The diagnosis of the gestational diabetes mellitus made when only if have one reading. اوكي، يعني إذا كانت قراءة واحدة عالية معناته إنه عندها gestational diabetes اللي هو سكر حمل. إما الصايم يكون 92 أو أكثر، ال1 hour يكون 180 أكثر من 180، ال2 hour يكون more than 153. اوكي، في طريقه ثانيه اللي هي القديمه الحين صراحه انا ما اشوف المستشفيات يستخدموها، اللي هي two step method using 50 جرام اوف ذا اول شيء في البدايه تكون البيشنت ما هي صايمه، نعطيها ال 50 جرام جلوكوز تشرب المحلول 50 جرام. اوكي، بعد ساعه اذا كان بعد ساعه اكثر من 130 نبدا نحولها نعطيها اللي هو يوم ثاني اللي هو 100 جرام اورال جلوكوز. اوكي، ال 100 جرام اورال جلوكوز تكون البيشنت فاستنج وتكون لازم قراءتين من 4 قراءات عاليه عشان اقول انه معاها سكر حمل. الصايم 95، بعد الاكل بعد المحلول بساعه 180، بعد المحلول بساعتين 155، بعد المحلول ب3 ساعات 144. لكن صراحة أهم شيء عندي هذا اللي هو ال 75 أورال جلوكوز تولرنس تيست. تجي المريضة صايمة 8 ساعات، أول شيء أقيس لها الصايم، إذا كان أعلى من 92 خلاص أساسا ما تحتاج إنها تشرب المحلول لأنه قراءة واحدة تكفيني، تمام؟ إذا كان طبيعي أخليها تشرب المحلول، بعد كذا أقيس لها ال1 hour 180، ال2 hour 153. تمام. طيب ليه مهم اني اسال عن الجستيشنال دايابيتس؟ لانه مو بس يزود اذر كونديشن، تمام، زي الكارديوفاسكولار ديزيز، زي الميتابوليك سندروم، زي انها تتحول الى تايب 2 دايابيتس، تمام. هذا الشريحه اللي اول تكلمنا عنها اللي هي التايب 1 والتايب 2 الباثوفيسيولوجي. في هنا ناس كانت تسال عن الديفرنشيشن بين التايب 1 والتايب 2 اللي هي بالاوتو اميونيتي. كيف افرق بين التايب 1 والتايب 2؟ عن طريق انه يكون التايب 1 عندهم شيئين، لو ليفل اوف ذا سي بيبتايد، هذا رقم 1، رقم 2 يكون معاهم اجسام مضاده اللي هي الايلت سيل انتي بودي، تريوزين انتي بودي، كمان الانتي جاد. اوكي، we talk about overview of management of the diabetes. أول شيء نتكلم عن glycemic target. طيب كيف إن إحنا نقول إنه البيشنت كنترول أو ما هو كنترول، البيشنت سكره تمام أو ما هو تمام؟ على حسب بارامتر عندي، الهيموغلوبين A1C أو القراءات المنزلية عن طريق اللي هو التراديشنال جلوكوميتر أو الCGM دحين حاليا فري ستايل ليبري، وفي بعض التحاليل زي البروكتازامين، الألبومين، تمام. طيب الهيموغلوبين A1C reflect average glucose was over approximately the previous 3 months. The A1C is the primary tool for evaluating glycemic control and has a strong predictive value for diabetes complication. هذا رقم 1. رقم 2 اوكي، كم مرة احنا نسوي ال A1C؟ نسويه كل 3 شهور إذا كان البيشنت uncontrolled diabetes. في حالات الكنترول diabetes every 6 months، يعني مرتين في السنة. اوكي، طيب انت دكتورة قلتي لي سكر التراكمي 8. ايش معنى انه السكر التراكمي 8؟ معناته انه السكر عندك الرينج حقه يكون من 147 إلى 217. هذا جدول مرة مهم، اوكي؟ لانه المريض مثلا يجيك على الاي 1 سي يقول دكتور انا حللت برا حصلت السكر التراكمي 10، انا ماني فاهم يعني 10 يعني كم السكر عندي يكون؟ معناته ان انت نقول انك انت ماشي بسكرك يكون من 193 الى 282. اوكي، طيب هل الاي 1 سي هذا اكيوريت او انه له ليميتيشن؟ طبعا له ليميتيشن في حالات اللي هو افكت الريد بلاد سيل تيرنوفر لايك جلوكوز 6 فوسفاتيز دي هيدروجينيز، هيموليتيك انيميا، بلاد ترانسفيوجن، اند ستيج كيدني ديزيز اند بريجنسي. عشان كذا في الحمل انا ما اعتمد ابدا على الاي 1 سي، نعتمد على القراءات المنزليه. other limitation، طبعا الاي 1 سي تقول لنا متوسط القراءات، لكن ما تقول لي هل هو البيشنت مر في 3 شهور بهايبوغليسيميا او لا، هل في جلايسيميك فاريابيليتي او لا. ليه؟ لان الجلايسيميك فاريابيليتي هي اللي حتحدد لي الكومبليكيشن، الدايابيتس كومبليكيشن زي ما تكلموا عنها الدكاتره في السلايدات اللي قبل. طيب دحين حاليا في اللي هو عندك عن طريق السي جي ام. السي جي ام هو يقيس لي الانترتيشال جلوكوز. الانترتيشال جلوكوز correlate with the plasma glucose when glucose level are steady. الريدنج طبعا may lag behind the plasma glucose if the glucose are rising or falling rapidly. هذه مرة مهمة النقطة. هي ايش تشرح لنا؟ انه اذا كان البيشنت يحس باعراض ارتفاع او اعراض الانخفاض اللي المفروض المثقف الصحي شارح له اياها، لازم ما يعتمد على السي جي ام اللي هو الحساس، لا لازم يقيس عن طريق الاصبع. ليه؟ لانه هي القراءة الصحيحة. تمام. السي جي ام ايش حيطلع لي؟ حيطلع لي ريبورت الحين حنشوفه، لكن الريبورت هذا يحتوي على ايه؟ يحتوي على عدد الايام اللي يكون فيها لابس الجهاز، هذا رقم 1. رقم 2 النسبه اللي كان فيها الجهاز اكتف، المين جلوكوز، الجلوكوز مانجمنت انديكيتور، الجلايسيميك فاريابيليتي، التايم اباف رينج 2 ليفل اند التايم ان رينج، التايم بيلو رينج. هذا هو الريبورت اللي يطلع لي من قراءاته لما يكون البيشنت على السنسور. اوكي، طبعا الدكتور يقرأ ويشوف ويوضح لي المريض. المفروض احنا نبغى يكون البيشنت التايم يكون معظم قراءاته تايم الرينج اللي هو اللون الاخضر، ما نبغى اللون الاصفر ولا اللون الاحمر. طبعا الاصفر معناته الهايبرغليسيميا، الاحمر معناته ان البيشنت هايبوغليسيميا. طيب التايم الرينج اللي احنا قلنا عليه اللون الاخضر معناتها correlate with A1C glucose management indicator. اوكي، may correlate with risk diabetes related complication. time below range assess for the severe hypoglycemia زي ما قلنا. التايم above the range اللي هو modify insulin time and dose. الجلوكوز variability مرة مهمة عشان correlate مع الديابيتس complication. اوكي، البنفيت فور سي جي ام اول شيء ممكن مينيمايز الهايبوغلايسيميك ريسك. الانفورميشن اللي ممكن احصلها من الريبورت، هذا هو الشيء الثاني. كمان الكومبليكيشن اوف ذا دايابيتس طبعا تقل كل ما قلت الفاريابيليتي. الجلايسيميك تارجت، طيب دكتوره كم الاي 1 سي اللي احنا نبغاه؟ تختلف على حسب البيشنت. يعني most non-pregnant adult نبغى ال A1C يكون عندهم less than 7. اوكي، less than 8 اذا كان البيشنت معاه comorbidity او limited life expectancy. طبعا حتى في الاطفال يختلف الموضوع على حسب الكوموربيديتي، على حسب الهايبوغليسيميك ريسك او لا. تمام، ايش هي التارجت اللي تحدد لي؟ ايش هي الفاكتور اللي تحدد لي ال A1C؟ على حسب رقم 1 عندنا risk potentially associated with the hypoglycemia and the other drug adverse effect, disease duration, life expectancy, important comorbidity, vascular complication, and the patient preference, and الريسورس الموجودة عندي أنا في البرايمري هيلث كير أو في الهوسبيتال. أوكي، حنتكلم عن النون انسولين ايجنت اللي ممكن نستخدمها في التايب 2 diabetes. اوكي. الدراج تارجت عندك الموجوده الحين حاليا، يعني مثلا اللي تشتغل على الانسولين سكريشن عندنا السلفانيوريا، الميجلانتايد، عندنا الانكريتين. اللي تشتغل عندنا على الجي اي تي اللي هو مثلا زي الانكريتين، زي الاوزومبيك والمنجارو اللي الحين حاليا اللي عليها الرجه، الالفا جلايكوديزيز انهبيتور، الاميلين، الهيباتيك جلوكوز اوتبوت اللي يشتغل عليها مثلا الميتفورمين اند جلايتازون، اللايبوتوكسيكيتي يشتغل عليها الجلايتازون، عند الجلوكوز ابتيك باي ذا مسل تشتغل عليها ميتفورمين اند جلايتازون، الجلوكوز ري ابزوربشن تشتغل عليها السي جي ال 2. طيب نجي عند البيجونايد اللي هو الميتفورمين. طبعا احنا هنتكلم عن كل دواء ايش اللي يعمله. يعني عندك البيجونايد الافيكسي حقته لور ال A1C from 9 to 1.4. طبعا الوزن حيكون زي ما هو ثابت and good safety profile. الموجود as metformin and glucophage. هو معظم البيشنت هنا يسمونه المنظم. تمام. oral tablet decrease the hepatic glucose by the liver and insulin sensitivity and the muscle. اوكي. السايد افكت حقته الجي اي تي ابست and ممكن لاكتيك اسيدوزيس. طبعا ما يستخدم في حالات اللي هو السيفير رينال امبيرمنت. كثير مرضى يجي يقولوا دكتوره هو يسبب مشاكل في الكلى. لا، هو ما يسبب مشاكل في الكلى. احنا نصحح المعلومه. هو يعني ما يعمل مشاكل في الكلى، لكن المريض لازم نحسب له الجي اف ار. على حسب الجي اف ار احنا نتحكم في الجرعه. هذا هو الجدول جدا مهم. نحسب الجي اف ار في معادله ندخل فيها الوزن والطول والكرياتينين، ندخل فيها العمر، وندخل فيها هو ميل او فيميل. اوكي. على حسب الجي اف ار اللي هو معامل ترشيح الكلى بالعربي. إذا كان أكثر من 60 نو دوز موديفيكيشن، خلاص زي ما هو، ويتابع وظائف الكلى كل سنة زي ما احنا متعودين. إذا كان من 45 إلى 60 ما نعمل لها موديفيكيشن، لكن المتابعة تكون من 3 إلى 6 شهور. إذا كان من 45 إلى 30 يفضل إنه احنا ما نبدأ، يعني أقل من 45 ما نبدأ. لكن إذا كان المريض اوريدي عليه، يعني من أول يستخدمه، خلاص نقلل الدوز حقته إلى من هي الماكسمايز دوز، الجرعة الأقصى حقته 2000، نقللها إلى 1000 باليوم. تمام. طبعا مع المتابعة. أقل من 30 لا، نوقف الميتفورمين contraindication to use. هذا النقطة جدا مهمة. تمام. السلفانيوريا حيقلل لنا ال A1C من 1.5 إلى 2. الادفانتج حقتها أنا موجودة، ممكن مرة أو مرتين. هي تشتغل على السلفانو سكراتوجينز. زود عندك الانسولين سكريشن. موجودة طبعا عندنا في وزارة الصحة على شكل دايمايكرون. أوكي. كثير من البشر أصلا يسمونه دواء السكر، يعني المنظم ما يسمونه الجلوكوفاج، يسمونه منظم، هذا يسمونه دواء السكر. اورال. السايد افكت هايبوغليسيميا. مره ننتبه، لانه الاولد ايج انا ما افضل الصراحه استخدمه في الاولد ايج، اخاف عليهم من الهايبوغليسيميا. اوكي. الويت جين اند انكريز ريسك اوف ذا كارديوفاسكولار ديزيز. النانسلفانيوريا زي البرغلانايد هذا جدا ممتاز، يقلل ال A1C 1.5 to 2%. نفس الطريقة يزود لي إياها increase insulin secretion عن طريق الأورال تابلت. أفضل شيء هو فيه إنه يستخدمه في البشر اللي معهم renal impairment. أوكي. السايد إفكت يعمل ويت جين ويعمل ريسك اوف ذا هايبوغليسيميا. الجلايتازون يقلل ال A1C تقريبا إلى من 0.7 إلى 0.8. في فائدة له الجلايتازون، ممكن إذا كان بيشنت دايابيتس وفاتي ليفر اللي هي يسمونها دهون على الكبد، ممكن استخدم له اياها. تمام. اللي هي البلاغاتازون اند الروز جلاتازون. بس هي تعمل ويت جين اند اديما اند ماكولر اديما اند هارت فيلير. يعني اذا كان البشر مع هارت فيلير، اذا كان مع ماكولر اديما، اوبيز، يفضل اني ما استخدمه. اوكي. الالفا جلايكوديز انهبيتور اللي هو الاكربوز يقلل لي نسبه ال A1C من 0.5 الى 0.8. good safety and lower postprandial hyperglycemia. اوكي. oral tablet بس ممكن يعمل GIT upset as side effect. السي جي ال 2 يقلل لنا الدوز باي 0.5 to 0.8. الممتاز في السي جي ال 2 انه له cardiovascular benefit من ناحيه reduce all cause cardiovascular mortality and reduce risk of the hospitalization in patient with heart failure, reduce and perceived ejection fraction and also have renal benefit. يعني ممكن يشتغل هو على القلب، يشتغل كمان تمام على الكلى، بالاضافه للسكر، وكمان يعمل ويت لوس. اوكي. فيشتغل على كذا حاجة. الموجود عندنا دحين حاليا في وزارة الصحة هو الإمبا، لكن موجود كمان عندنا الدابا أعتقد في البرايفت. الأورال تابلت. سي جي ال 2 هو يشتغل على الكدني تبيول يعمل ري ابزوربشن للجلوكوز. السايد افكت ممكن يعمل اللي هو الانفكشن عند الديهايدريشن عند الايوغليسيميك ديكي. فاحنا شو نقول للمرضى؟ إذا بيشربونه يشربونه الفترة الصباحية، عشان ممكن يعمل لهم يروح الحمام كثير خاصة في أول الأيام، يشربوا موية كثير. إذا كان old agents يشربوا موية. DB4 decrease ال A1C 0.6 to 0.8 good safety profile في الناس الكبار في السن. safe in patient with reduced GFR linagliptin very effective linagliptin in patient with low GFR and patient with the renal dialysis. okay. الباي اورال طبعا النوزيا والفوميتنج نفس الشيء، تشتغل على السايد افكت نوزيا فوميتنج ممكن تعملها. اوكي. الجي ال بي decrease ال A1C by 0.7 to 1.9 promote weight loss reduce the risk of the cardiovascular disease and improve fatty liver. يعني احنا الحين عندنا دوايين تعمل improve الفاتي ليفر، الجليتازون عند الجي ال بي. no renal clearance. بتعمل stimulate الانسولين release in glucose dependent manner, decrease the glucagon at pancreas, decrease the hepatic glucose production, increase the incretin effect اللي قلنا اساسا هو في الباثوفيسيولوجي عنده decrease في البيشنت اللي معهم diabetes. help with the state at brain, improve insulin sensitivity at the muscle. اوكي. الموجود عندنا دحين تروليستي once weekly. عندنا الليروغلوتايد نفس الشيء once daily. السيماغلوتايد once weekly. موجودة اورال اللي هو فقط السيماغلوتايد الاورال او السبكوتينيوس. السايد افكت حقتها نوزيا فوميتنج بس في خاصة في تروليستي اند في الاوزومبيك السيماغلوتايد تكون السايد افكت في اول اسبوع تقريبا، بعد كذا حتخف تدريجيا، على ثالث رابع اسبوع تختفي الاعراض اكثر البيشنت. في شيء ثاني كمان، البيشنت قبل ما ياخذ الجي ال بي انجكشن في بعض الادفايس ممكن اعطيها للبيشنت تقلل السايد افكت. يعني نقول للبيشنت حاول نفس اليوم اللي تاخذ فيه الانجكشن يكون اكلك قليل، تكون تبعد عن الاكلات اللي تكون فيها زي مثلا الزيت او التوابل، يكون البيشنت يشرب مويه، اكله يكون صحي قد ما يقدر هذاك اليوم. اوكي. الجي ال بي and الجي اي بي ريسبتور اجونست اللي هي اللي منجاره حاليا decrease ال A1C 1.6 to 2.4 promote significant weight loss تقريبا after 74 weeks by 20%. نفس الاكشن تبع السيماغلوتايد بلس ستيموليت الانسولين ريليز زي ما قلنا، decrease الجلوكاجون at pancreas, decrease hepatic glucose production, improve insulin sensitivity اللي هو once weekly injection subcutaneous يعمل الجي اي تي ابسيت as side effect. تمام. احنا كده تكلمنا عن تكلمنا عن الاورال هايبوغلايسيميك بلس الانجكشن. نيجي نتكلم عن الانسولين. البرايمري تارجت انه يعمل ستيموليت للجلوكوز ترانسبورت اكروس السيل ممبرين. طبعا هايست عندنا موجود هذا الكومباريزون بين التايب اوف ذا انسولين على حسب الموجود. عندنا الالترا فاست، الرابيد، شورت اكتنج، انترميديت اكتنج، لونج اكتنج، الترا لونج اكتنج اند وانس ويكلي الان. تمام. يختلف على حسب الأونست اوف اكشن اند البيك اند الديوريشن اند النيم على حسب الاسم. جدا مهم المريض يعرف الفرق، جدا مهم المريض يعرف الفرق. جاني مريض الاسبوع اللي فات قال لي دكتورة انا زوجتي استخدمت الهومولوج 100 مرة واحدة بعد الأكل بعد العشاء، أخذت 40 وحدة، طاح السكر عندها نزل السكر 60. أنا استغربت، إحنا ما نعطي الهومولوج بعد الأكل 100، هو يعتبر شورت أكتنج الهومولوج. تمام، يعني يعتبر شورت أكتنج، ما نعطي الهومولوج بعد الأكل، استحالة. هذا رقم واحد. رقم اثنين، ما نعطيه مرة واحدة والمريض ياخذ 3 وجبات أو وجبتين. فإيش اللي فلما رجعنا بالهيستوري طلعت ملخبطة. تحسب الهومولوج بدل الليفيمير، يعني بدل ما تاخذ الليفيمير 40 تمام، لا أخذت الهومولوج 40 واخذت الليفيمير قبل الاكل 10 يونت، فبس دخلت في هايبوغليسيميا. الحمد لله انه ما صار لها حاجه. فمهم البيشنت نشرح للبيشنت، جدا مهم نشرح البيشنت هذا شورت اكتنج، ناخذه قبل الاكل ب5 دقائق، وقديش ينتظر المريض قبل ما ياكل. تمام. هنا نفس الشيء مكتوب، يعني الرابيد اكتنج ايش الاسماء الموجوده عندنا. اوكي. وين should insulin therapy patient اللي معاهم تايب 2 متى أبدأ انسولين؟ إذا كان ال A1C فوق 10، إذا البلد جلوكوز فوق 300، إذا كان البيشنت معاه ويت لوس، أو إذا كان البيشنت still ال A1C uncontrolled الآن سكره 9 وهو آخذ 3-4 ميديكيشن أورال. أوكي، نبدأ نعطي له الانسولين. أوكي، إذا كان ال A1C نبدأ هنا، إذا كان ال A1C فوق التارجت يعني فوق 7 بس إنه الصايم كويس، الصايم عنده أقل من 130. أوكي، نبدأ نبديله بازل بلس إذا كان معاه ممكن انجكشن. إذا كان ال A1C above التارجت معاه سيمتوم، لا نبدأله بازل، نبدأله الجرعة 0.1 to 0.2 نضربها بالوزن. أوكي، ونبدأله بعد كده على حسب الافيلابيلتي الموجودة عندنا. أوكي، الباشنت تستل على بازل ونفس الشيء هنا مثلا عندك أول شيء بدنا له انجكتبل. إيش معنى انجكتبل؟ اللي هو بالجرعات بالأقلام. بدأنا له أوزمبيك، بدأنا له ترولستي، بدأنا له منجارو، هو أساسا حتى هنا كاتب إنه consider GLP most patient before insulin قبل الأنسولين. أوكي، patient still above التارجت، نبدأ له بازل أنسولين. نفس الشيء البازل أنسولين ما فاد معاه، نبدأ له بدأنا له البازل أنسولين، بدأنا له باي 0.1 to 0.2 يونت بير كي جي، شفنا الفاستنج وبدأنا نزود في الجرعات. خلاص اوكي، ستيل البازل مرتفع او انه ستيل عنده البوست برنديال بعد الاكل، نبدا له اللي هو القصير المفعول. اوكي، باي 4 يونت نبدا له او 10% من قيمه البازل. اوكي، طبعا بعدين متابعه تكون الزياده تكون 3 يونت 3 يونت نبدا سوري 2 يونت every 3 days. اوكي، هنا نفس الفكره متكلم لي عنها هنا الريفرنس وكذا. إن شاء الله نكون خلصنا المحاضرة. إذا في أي سؤال أو استفسار على الشات ما في إشكالية. ما أدري في أي سؤال أو شيء. سواء بالشات أو بالمايك ما في إشكالية. if hemoglobin A1C and patient refuse. اوكي، اذا كان الهيموجلوبين A1C عالي والباشنت ريفيوز الانسولين، اول حاجه يا امل ضروري اذا كان عندك البيشنت سكره فوق 10، اذا كان فوق 300، اذا كان معاه هايبرغليسيميك سيمتوم، ابدا اقنعيه في البازل انسولين، يعني جاست قلم واحد تمام في اليوم 10 يونت. اوكي، لونج اكتنج البيشنت جدا ريفيوز تو تيك الانسولين، اقنعيه باللي هي وانس ويكلي اللي هي ترولستي، او اذا كان طبعا على برايفت اللي هو زي الاوزمبيك او المنجارو. تمام، بيشنت ريفيوز الانجكشن ما لنا غير اللي هو السلفانيوريا بلس الميتفورمين. يعني ترى السلفانيوريا بلس الميتفورمين حتى الدراسات عليها ممتازه انها تعمل الهيموجلوبين A1C انه يكون كنترول. في بلس اللايف ستايل موديفيكيشن ترى ما تكلمت عنه، هذه الحال ومحاضره. اللايف ستايل موديفيكيشن جدا مهم جدا مهم، يعني ديكريز ال A1C by 2% تقريبا. طيب it is possible to share presentation with us. إيه ما في مشكلة، أقدر أرسلها نفس هذا وأرسلها لكم، أرسلها هو لكم عن طريق الإيميلات وهذا ما في إشكالية. طيب ماني عارفة في أسئلة أو شيء. كم المدة اللي تحتاجها الأدوية حتى طيب المدة اللي تحتاجها الأدوية عشان تنزل ال A1C، أساسا أنت ما حتطلب ال A1C إلا كل 3 شهور، ما حتطلب ال A1C قبل كذا ما حيستفيد البيشنت. تمام، طيب أي علاج أي ميديكيشن عشان يبين افكت على بلاد جلوكوز أقل شيء ياخذ 2 weeks. تمام. كيف أعرف هال2 ويكس إنه أثر؟ عن طريق إيه؟ عن طريق القراءات المنزلية. فعشان كذا لما أنا أقول للمريض المتابعة عندنا غالبا في وزارة الصحة كل 3 شهور، إلا إذا كنت تبغى المريض يجيكي قبل، أنا ما أقول له تعالي روح سوي الA1C، لا، أقول له تعالي بالقراءات المنزلية اللي هي الجدول، يقيس لي أهم شيء. طبعا المرضى أكثرهم ما يرضوا يقيسون، بس حاولي فيهم يقيسوا لك الصايم وبعد الأكل. أول شيء اسأل المريض كم وجبة تاكل، ترى يختلف المرضى، في بيشنت 3 meals، في بيشنت 2 meals، في بيشنت 1 meal. قولي له أبغى صايم أول ما تصحى من النوم، واشرحي له إيش معنى صايم أول ما تصحى من النوم. والشيء الثاني أبغى القراءة بعد الأكل بساعتين. مهم ترى تشرحوا له صايم أو بعد ما اللي هو لما تصحى من النوم. في مريضة جاتني سكرها حامل، سكرها كان 140 150 الصايم، في أيام كانت كويسة. مع الهيستوري عرفت إنه قصدها 140 150 إنه الفجر، وات ايفر كانت سهرانة أو لا. طب هذاك اليوم طبعا كان سهرانة وكان في قهوة وحلا وكذا، فعشان كذا السكر كان مرتفع. فالهيستوري جدا مهمة صراحة عند البيشنت. إذا في سلايد تبغون أعيدها عشان يعرف أنا سريعة في الكلام، تبغون أعيدها أو شيء، ما في إشكالية أعيدها. طيب what about combination of sulfonylurea and insulin؟ اوكي، مرة سؤال مهم هذا. اذا كان البيشنت انت اعطيتي، طبعا حتكوني ماشية من البداية على السلفانيوريا. اوكي، احنا نقول انك كنت على الماكسمايز دوز اللي هو 120 الدي مايكرون، حلو تقريبا اللي هو وزارة الصحة تكلم، لانه يعني غالبا احنا اكثرنا وزارة الصحة. طيب انت تكوني ماشية عليه، اساسا انت ما زدتي الانسولين، ما زدت الانسولين الا انه هو above target. اوكي، طيب كان البيشنت above target وتبديله غالبا 10 يونت اللي هي قلنا عليها البيز الانسولين، ايش تقولي له؟ تقولي له في البدايه احنا ما حنقلل لك الجرعات، تمام؟ مو انه حنقول لك على حسب البيشنت انديفيدواليزيشن. كل بيشنت انت تعرفين حالته. جاكي مريض عمره صغير، يعني في ال40 في ال50 في ال60، تمام، ما هو كبير، شايفته انتوا انه ويل اديوكيتد، حيفهمك، حيسوي قراءات في البيت. طيب هذا لا تقولي له السلفانيوريا، عادي قولي له انت حتمشي على 120 وحتمشي على 10 يونت. لكن في حاله عندك حسيت باعراض هبوط، واشرحي له اعراض الهبوط، قولي له حسيت برجفه، حسيت بعرق، حسيت بزيادة في الجوع، حسيت بعصبية، قست السكر حصلته أقل من 70، تمام. ولازم تشرحي له الفرق بين السودو هايبوغلايسيميا والهايبوغلايسيميا، الهبوط الكاذب والهبوط اللي أقل من 70، تمام. طيب حصلت السكر حقك أقل من 70، حسيت بأعراض السكر، أخذت شيء حالي ارتفع السكر، ما كان له سبب الهبوط، مو قعدت 9 ساعات ما أكلت بعدين جاك هبوط، ما كان له سبب، لا، في هذه الحالة تقلل 120 قللها 90، تمام. طبعا هو ما حيجيكي انت، لان انت متابعاتك كل بعد 3 شهور وانت عندك مواعيد، ما حيجيك المريض كل شويه، تمام. خلاص انت انتبه، لو حسيت بالهبوط قلل 120 قللها 90، حسيت بالهبوط وانت على 90 قللها 60، تمام. لازم نشرحها للمريض. ايش هو بالعربي؟ السكر التراكمي. غالبا السكر التراكمي هو اساسا المرضى يحفظوا، يقول لك 10 8. هيموجلوبين A1C كم أبدأ دواء على حسب، يعني إذا كان الA1C فوق 10 أنت غالبا حتبدي له انسولين أو انجكتبل، تمام. وأساسا الانجكتبل اللي هي الأقلام يفضل اللي هي GLB تروليستي ولا زومبيك أو المجرد، تفضل على الانسولين. طيب بعد كذا أنت تبدأ على حسب التارجت اللي أنت تبغيه، على حسب البيشنت كونديشن. الصوت راح من عند السكر الكذاب. طيب هو مو سكر كذاب، هو هبوط كاذب، تمام. الهبوط الكاذب ايش هو؟ كثير من المرضى يكون السكر التراكمي حقهم مثلا 10، اوكي، ان كنترول، قراءاته في البيت 300 200 300 200، انت بدأت تعالجيه. طيب لما تبدأ تعالجيه انت تنسي تقولي له انك انت احتمال يجيك اعراض هبوط، طيب بس لو تحصل السكر تحسه 90، هو يا حرام يشوف ال90. طيب دحين نشرح التايم رينج. يشوف ال90 كأنه هبوط، يقوم ايش يسوي؟ يقوم ياكل سكر، يقوم ايش يصير في السكر؟ يرتفع، فدخلنا في دوامة. ايش حلها الدوامة؟ حلها شيء بسيط، تقول للمريض انه هذا اسمه هبوط كاذب، حتى قولي له في الكتب مكتوب هبوط كاذب. تمام؟ يكون السكر أكثر من 70 وتحس بالأعراض. لا، حلو ترتاح وتشرب مويه وتقيس السكر بعد فتره، حيرتفع السكر، لا تخاف، لا تصحح السكر الا اذا كان اقل من 70. كان يو اكسبلين مور اباوت تايم رينج. ايش معنى تايم رينج؟ معناته انه قراءات المنزليه او القراءات اللي انت سويت عليها سكان بالفري ستايل ليبري اللي هو بالحساس، تكون ما بين التارجت اللي انت حاطه. انت حاط تارجت للسكر حق مريضك، حاط انه يكون السكر تقريبا من 80 إلى 130 أول ما يصحى من النوم، وحاط إنه يكون أقل من 200 أو أقل من 180 بعد الأكل. هل هو في القراءات هذه أو إنه أعلى منها؟ هذه معناته التايم رينج. هل قراءاته اللي سواها، المسحات اللي سواها لما فحص يده، هل كان السكر مع وذن الرينج اللي انت حاطه، ولا كانت في قراءات أقل من 70 أو أكثر من 250؟ هذه كلمة تايم رينج. أنا عشان الفرق بين السكر النوع الأول والسكر النوع الثاني أسباب كثيرة. يعني أول شيء من ناحية إنه هذاك السكر النوع الأول يكون مناعي، تمام، غالبا أسبابه. النوع الثاني لا، له أكثر من سبب. النوع الثاني طريقة العلاج في النوع الأول غير عن النوع الثاني. ما أدري كذا خلصنا، لكن هل نقدر نقفل الآن أو لا؟ فما عندي فكرة. اللهم آمين. أعتقد إنه كذا خلصنا إحنا الحين، لأنه ما شاء الله ما في أي سؤال جاني. بس إن شاء الله تكون يعني فهمتوا المحاضرة بإذن الله تعالى واستفدتوا أهم شيء. أعتقد كذا خلاص حتكون ما في محاضرة بعد كذا، لأن كنت آخر المحاضرة في الجدول. يعطيكم العافية والله. أيوة أعتقد أنا ما في محاضرة، كانت محاضرتي آخر محاضرة. ثواني بس. يلا. إذا كان المريض بمرحلة ما قبل السكري، إحنا نقول له المريض ما قبل السكري. أنا قبل شوية كنت في العيادة، لازم أنا كنت مريضة والله ما قبل السكري. أقول له أنا في خبرين، خبر كويس وخبر مو كويس صراحة. الخبر السيء إنه أو اللي يحزن يعني إنه مريض ما قبل السكري أكثر عرضة خلال ال5 سنوات الجاية إنه يجي سكر. تمام. الخبر الحمد لله إنه بس لو نزلت 5 كيلو من وزنها راح ترجع طبيعي. تمام. هذا رقم 1. ممكن إنها تمشي على حبوب الميتفورمين، لكن النسبة إنها تنزل عن طريق الحمية والرياضة 58%، لكن مقارنة بالميتفورمين تقريبا 36%. طيب متى نقول لها ما احنا يمشون على الميتفورمين؟ اذا كانت فوق 60، واذا كانت البادي ماس اندكس فوق 30، واذا كانت المريضه قبل كذا سكر حمل، ممكن نمشيها على الميتفورمين، لكن الرياضه والتغذيه افضل لها احسن لها. اعتقد خلاص تقدروا تخرجون كذا، لانه انا اخر محاضره واحنا الحمد لله خلاص خلصناها. يعني خلصنا المحاضرة، أنا خلصتها، حاولت أني أخلصها بسرعة لأنه الوقت متأخر. لو خلصنا على 10 الوقت متأخر، دحين 9:30 يعني أفضل من 10، لأن فنعتبر إنه هذا كان وقت بريك وقدمناه. تقدروا تخرجوا. يلا يعطيكم العافية إن شاء الله جميعا، وإن شاء الله الجميع استفاد. شكرا لكم.